Adar Abhinandan Abhar, Namaskar, Adab Sat Shri Akal. Hello and a very good morning to everyone present here. On the behalf of WinCars, I, Dr. Sanchit Mishra, would like to welcome you all to this very wonderful gathering of brilliant minds, 18th Women Cardiac Care Conference 2026. They say, knowledge is not a destination, but the journey. So ladies and gentlemen, to begin this journey officially, I'd like to invite President of WinCars, Dr. Sarita Rao ma'am, to kindly give the welcome note. Ma'am, please.
Good morning, ladies and gentlemen, and a very warm welcome to all of you on behalf of the WinCars organization. WinCars is basically a family which strives together for academic collaborations and for the cause of women's health. Our organization was founded way back in 2007 by 4 amazing ladies, and today look where it has reached with over 500 ladies. WinCars, whenever we have a meeting of WinCars, our meeting is never complete without the mention of our founder, Dr. Jyotsna Madari. She was with us in the hall upstairs, and unfortunately, Madam is not well and cannot travel, but we never forget the contribution and the legacy of Dr. Jyotsna Madari in creating this WinCars organization, which all of us here today are carrying forward. So welcome all of you to WCC 2026, and without any further delay, we will start with the academic session. Thank you.
Thank you so much, ma'am. Ladies and gentlemen, today we are not just here to share knowledge, but to exchange ideas, inspire innovation, and strengthen the spirit of collaboration. So let's open our first segment of scientific sessions about heart failure. Ladies and gentlemen, let's invite our chairpersons, Dr. Anita Saxena ma'am, Dr. A.K. Pancholia, and Dr. Tripti Deb. I'd like to request our chairpersons to kindly take their seats on the dais. Now I'd like to invite our expert panel, Dr. Rai Ayoma, Dr. Channaprada Sridevi ma'am, and Dr. Maria Jyoti ma'am. I'd like to request our expert panelists to kindly take your seats on the dais. And to moderate the sessions, I'd like to invite Dr. J. Cicely Majila ma'am. So without any further ado, ladies and gentlemen, let's begin up with our first talk. And please welcome our honorable speaker, Dr. S. Shanmugasundaram, who will be talking about stress cardiomyopathy from mind to myocardium. I request you all to please have a big hand to invite our honorable speaker.
Can I have the presentation, please? It is there. Okay, thank you. Good morning. Thank you, WinCars, for this great opportunity to talk on stress cardiomyopathy. It goes with different names, Takotsubo cardiomyopathy, ampulla cardiomyopathy, apical ballooning syndrome, etc. It is an acute, transient, regional left ventricular dysfunction, often circumferential in distribution, crossing beyond the boundary of a single coronary artery territory, precipitated by emotional or physical stress, and mimics acute coronary syndrome in clinical presentation. If you look at the incidence, it's roughly 15 to 30 per 100,000 per year in the West, contributing to 1 to 3% of people who come with acute coronary syndrome, little larger number in women with acute coronary syndrome. What was considered to be disease of postmenopausal women, often precipitated by emotional stress, now we believe that more number of men are affected, more number of youngsters are getting involved. Physical triggers are becoming more common. Association with medical illnesses, particularly the lung diseases, neurological diseases is getting to be known, and higher number of associated coronary artery disease is also evident. Roughly 1/3 is precipitated by emotional stress, 1/3 by physical stress, that's becoming 1/2 now. No trigger in the other 1/3. Apart from negative emotions, even positive emotions can precipitate this illness. There are hundreds of possible triggers of this syndrome. It is divided into primary Takotsubo, where the mode of presentation, it is the primary mode of presentation following a stressful event. Secondary Takotsubo is a part of systemic illness like sepsis. There are various criteria laid down by Mayo, Heart Failure ESC, and Intertac Society. Common things among these recommendations are occurrence of transient LV dysfunction, which almost improve totally, involving in a circumferential manner, non-conforming to a single coronary artery distribution, precipitated by stress, presenting with chest pain, dyspnea, or syncope, or even resuscitated cardiac arrest, new ECG changes, elevated cardiac biomarkers. There are subtle differences between these criteria. For example, Mayo doesn't include pheochromocytoma as a trigger, while other two criteria include pheochromocytoma as a trigger. And Intertac criteria even goes to the extent of including a significant coronary artery disease as a part of the syndrome or even a precipitating event. Based upon the location of wall motion abnormalities, it is divided into apical variety, which is the commonest one, nearly 80%, mid-ventricular 15%, basal or focal. Very, very rarely it can be global, and biventricular even. Pathophysiology is elusive, most probably multifactorial, starting with physical or emotional stressors acting through the brain-heart axis, resulting in catecholamine surge, both locally and systemically, microvascular dysfunction, contribution by microRNAs, and inflammation, so on. Presentation in the ECG, something like ACS, ST elevation in 40%, T-wave inversion another 40%. But remember, ST segment depression is quite rare in Takotsubo cardiomyopathy. If you try to differentiate it from acute coronary syndrome, somebody with ST elevation, in Takotsubo, the ST elevation is predominant in V3 to V6, distinctly absent in V1. ST depression is a phenomenon in Takotsubo in AVR, while it may be elevated in acute coronary syndrome. Similarly, prolongation of QT interval, very deep, broad T waves in the precordial leads is again a manifestation of Takotsubo. What is more important is the disparity between troponin and BNP. In Takotsubo, troponin is mildly elevated because it is only a stunning of the myocardium, not a muscle necrosis. But in the contrary, the pro-BNP levels are markedly elevated in Takotsubo. In contrast, in acute coronary syndrome, troponin is mostly elevated to a larger extent. This study, involving small number of people, looked at the ratio of NT-proBNP divided by cardiac troponin, both expressed in picogram per ml. If the ratio is more than 7.5, it is supposed to be diagnostic of Takotsubo. Echo, gives you the diagnosis. This is the typical apical ballooning variety. Someone may present with dynamic LVOT obstruction. You could see a systolic anterior motion of the anterior mitral leaflet, resulting in dynamic gradient, late peaking gradient, and associated mitral regurgitation. Within 48 hours, both the wall motion abnormalities and the LV outflow obstruction resolved. Here is a young lady who had presented with reverse Takotsubo. Look at the base, it is dyskinetic, the apex is hypercontractile. Resolved again within a day. If you look at the strain pattern also, it goes with the diagnosis of the basal variety where the base is poorly contracting, apex is hypercontractile, normal coronaries. This followed administration of IV epinephrine by a family doctor for presumed anaphylaxis. This lady, elderly female, presented with global ST elevation, V1 ST depression, AVR ST depression, we thought it is Takotsubo. Echocardiogram also. Can you try to move that? It's not moving. Shall I put it to restart, or restart means it's going to take longer time? Next, yeah. No, it was playing when I saw that. Look, can you go to the next slide, if not this? Actually, hold it. A larger file and all that. Thank you. I'll move it. One second. Global ST elevation in anterior leads, ST depression in AVR and V1, that Takotsubo. Echo also suggested that it is an apical ballooning one. Even LV angiogram was very typical, but look at the color angiogram, very severe stenosis of LAD and significant stenosis of RCA. So this is just to tell you that one can have Takotsubo along with significant CAD, and at times acute coronary syndrome may be a trigger for Takotsubo. This is an example of what we call a pseudo Takotsubo. Look at apical four-chamber, apical ballooning is the suspicion is stronger. But if you look at the short axis view, the wall motion is not circumferential. The infralateral wall contracts normally. Angiogram revealed occluded LAD which was opened up. So obstructive CAD may coexist. ACS may be triggered. This is Intertac diagnostic score based upon the clinical presentation. If the score comes more than 70, it is diagnostic of Takotsubo syndrome. CMR is valuable in documenting edema in the acute phase, no LGE, or at times focal LGE at the hinge point between the hypercontractile segments and the hypocontractile segment. Recovery occurs mostly. Time is variable. Those who show delayed recovery don't do well. It is not a very benign illness. Mortality 5%, cardiac arrest 5%, cardiogenic shock 10%, atrial fibrillation, ventricular tachycardia can happen. And if you look at the treatment, is very limited. Someone with acute heart failure, AC inhibitor or ARNI, beta blockers are useful, but they don't prevent recurrence. It is quite useful in LV outflow obstruction. Anticoagulants for those with thrombus or embolism. In someone with shock, avoid beta sympathomimetics. Alpha adrenergic agents, vasopressin, or angiotensin would be an alternative, or mechanical circulatory support. Mechanical circulatory support, particularly IABP, should be avoided if there is LV outflow obstruction. Recurrence can occur in 4 to 5%. Long-term outlook is not very good. It is worse than acute coronary syndrome. Thank you very much.
Thank you so much, Professor Dr. S. Shanmugam sir, for coming all the way and showing us excellent demonstration of wonderful cases. Any of the co-chair or the panelists, expert panelists, your opinion or questions, ma'am?
I'm not really, dealing with this disease, but I was very surprised. Initially, we used to call it quite benign, and now you are saying it is worse than CAD. So obviously, this is kind of a paradox change that we have had.
I think we have been missing Takotsubo that occurs in medical illnesses. When it was precipitated solely by an emotional stress, prognosis is quite good. But if it is precipitated by physical stressors, when it occurs in men, we have been missing that. And particularly in medical illnesses like sepsis, the prognosis is much worse. That's why the outlook is much worse than acute coronary syndrome.
But you said three criteria. So in only one coronary disease has been included. One or two, I think.
Yeah, only one.
So those who do not have underlying CAD, do they behave better?
Obviously, yes. They do better.
We take modified Mayo Clinic criteria.
Sorry?
More specific, modified Mayo Clinic criteria. Mayo Clinic criteria.
Modified, that's what I projected. Everything is more or less the same. But in Mayo criterion, pheochromocytoma is excluded. Significant coronary artery disease is excluded. But I think we should go by intertact criteria because, it is all inclusive. And the latest probably, 2018.
And what about in hospital outcome?
In hospital outcome, as I projected, the mortality is close to 4 to 5%. Cardiogenic shock occurs in about 20%.
Thank you very much for this excellent presentation. Takotsubo cardiomyopathy is a disease and the concept originally proposed in Japan. So it is now widely recognized, very honorable. And also it is often considered to have a favorable prognosis. But in the real practice, sometimes complicated by, you said, left ventricular obstruction or thrombosis in the left ventricular. And do you have any thought on what kind of patient may likely to develop these complications?
What type of patients
So
go through the
likely to have a complication like LVOTO or maybe sigmoid septum patient?
Yeah.
Often occur the LVOTO.
One is the phenotype. If someone has mid-ventricular type, they don't do well. And as I mentioned, physical stressors, they don't do well. Men, they don't do well. And delayed recovery, if someone doesn't recover LV function within 10 days, they don't do well.
Thank you.
So can
In Jack, they have described that LPP can occur in Takotsubo cardiomyopathy and that LPP persists even after the recovery of Takotsubo. It is one of the rare ECG changes of Takotsubo.
Which one?
Left bundle branch blocks.
LVB, I think about 5%, it can happen.
And it persists even after the recovery of Takotsubo.
Yes, that's right.
Yeah, one.
Yes, ma'am.
So a very nice presentation, sir. That was wonderful. In fact, when they did the coronaries, they were normal, so they thought it is benign. But later on, they realized that nothing can be done, and that's how they started worrying. But I didn't find you mentioning about the the meditation, that is the transcendental meditation that they followed from Mahesh Yogi. And within 72 hours, the whole ejection fraction and the whole thing reverted back to normal. So I think the stress levels will come down, endorphins and neuropeptides are released when the meditation is done, and that is the best way to get back the functioning of the heart. Thank you.
Thank you.
I just wanted to congratulate you. Your videos came on well despite a small glitch. To answer your question, I'm a cardiac anesthesiologist, and we see a lot of Takayasu coming for a CABG with septectomy. And where do we see it bad? You rightly pointed out LVOT obstruction with anterolateral or a septal, particularly a septal hypokinesia, where your regional wall motion score is much more than, wall score index is more than 1. Those are the patients who don't do well. We can't put an IABP. We do think of before, even at PCI, ECMO, but I think these are the patients who go into RV failure. Very often we see them post-op in RV failure, and any amount of milrinone or any such drug is not enough, and you need an impeller, which we don't use in a country like India so often, at least not in our center so far. And therefore, we are at a loss in the post-op period. They don't do well. LVOT obstructions with acute coronary syndrome and Takayasu. It is very common. It is coming up. It is seen more in males. And I think, ma'am, the female ones were better with the meditation. The ones which come on in young male, as you mentioned in one of your subgroup, I think those don't do well. We just had recently 3 of them, 2 survived, and 1 we lost on day 8. So it's not a good disease. One should be very wary. Thank you.
Thank you.
Thank you, sir. Thank you, sir, for the great talk. Now I request Dr. Zakia Khan, who's giving a talk on powering heart failure, GDMT, through hyperkalemia control. Over to you, ma'am.
Can you project the slides here? Can I see them in full screen?
And just 1 minute. Yeah, they wanted to shift the chairs.
Yeah, because it's kind of obstructing the... Do you want to take this in the front or something? Yeah, it's okay. I'll just come there. Good evening, friends. Congratulations to Team WCC for such a wonderful scientific program. We all are very confident of our GDMT for heart failure, but you know, a stage comes in heart failure when you get stuck, when the patient's kidney gets affected, or you start, you know, getting troubled by hyperkalemia. Heart failure is a disease which is increasing by leaps and bounds, especially in India, we being the diabetes capital of the world. The heart failure mortality risk is really rising by leaps and bounds, almost 10 million people in India. Now, all guidelines recommend that we use all the GDMT, and if there is hyperkalemia, what do we do? Majority of the time, our reflex is to take off MRAs, then take off ACE, ARNI, start reducing or just take off. But remember, the guidelines tell you that they should not be de-escalated or discontinued because of hyperkalemia, because we have now drugs that can help us. Why? Because de-escalation really increases mortality by leaps and bounds. You can see the difference that if you receive comprehensive therapy, you prolong the life by almost 13 years. And if you don't, the life, it really goes down by 50%. What is the biggest hurdle in all these drugs? One of the biggest hurdle is hyperkalemia. The prevalence about 25 to 40% in over 1 to 3 years of period in heart failure patients, and it is almost 26 to 48% in patients who have combined CKD, and less than 1% in general population. The risk factors being CKD first, diabetic kidney disease, combination of RAS, MRA, ARNI, and age-related and very bad disease. If your your LV function goes down, then that is the reason. What is its implication? You develop life-threatening arrhythmias, increased mortality, and of course, adding to the mortality is dose reduction of life-saving drugs. In real-world practice, patients with HFrEF frequently miss out on life-saving drugs. MRA, only 33%. 75% patients are not able to continue with optimal RAS because of these reasons. You can see the variable risk of hyperkalemia across patient population, ranging from 40 to 50% in CKD patient to almost 8 to 17% in resistant hypertension and just 2.3% in general population. Despite dietary restrictions, although we do have a culture of drinking coconut water, nariyal pani for any sick patient, I tell all my patients to avoid all this. Despite that, patients have almost 56 to 68% recurrences of hyperkalemia. And doing down titration really harms the patients. So this strategy of down titrating these drugs eventually leads to problem. And what you see in the orange is add a binder. This is a current recommendation now, that do not do this because down titrating is as harmful as RAS discontinuation. So 55% increase with RAS discontinuation and 51% increase with RAS down titration. Same with MRA. So this is one of the most important cause of down titration and discontinuation. So what are the options? Of course, we all try non-pharmacological options of limiting dietary drugs, reducing medications, and avoiding addition of drugs that cause hyperkalemia. Pharmacological treatment, we all know, we use diuretic, we use soda bicarb, we use GI drips, and then we even go down to K-bind resins. So what is the current guideline recommendation? KDIGO says newer potassium binders may help facilitate essential use of all the necessary drugs. They should be considered before reducing these agents, and RAS discontinuation should be the last resort. So potassium lowering agent may be initiated as soon as potassium levels are confirmed as more than 5 milliequivalents. So administration of potassium lowering agents like sodium zirconium may allow RAS inhibition or uptitration in a larger population. So this is a new novel oral potassium binder called Lokelma or sodium zirconium. This has a specialty of having a larger area of binding in small intestine, large intestines, and it's highly selective for potassium binding site with an potassium ionic diameter are similar. It's insoluble, highly stable, and does not expand in water and is not absorbed systemically. There are multiple trials like Harmonize extension studies of various doses along with placebo over a long-term period after 48-hour correction. You can see the period was very long with, you can see that the mean time to potassium normalization is just 2.2 hours. So many of my patients whom I thought that I might have to shift to ICU, just giving a sachet delayed or avoided this ICU shifting of the patient. Patients achieve normocolemia almost 84% by 24 hours, 98% by 48 hours. So does this drug help reduce in heart failure potassium who are on ARNI and MRA? So there is a realized potassium studies which does show that proportion of patients achieving normocolemia on spironolactone and not on rescue therapy were far greater. So almost 63% relative risk reduction when you combine this agent along with your conventional heart failure drugs. Does it translate into real world evidence? You can see that there is a 83% of patients continued RAS use following this administration. Almost 40% lower rates of ED visits and emergency visits, and the patient did not require to come back to hospital for hyperkalemia. So there was an increased uptake and dosing of guideline-directed therapy with the use of this. So MRA, you can see, increased from 52% to 93%. All the recommended drug therapy increased from 68% to 91%. So with very low dose of SCZ. And of course, it translated in patient improvement, LVF improvement, reduction in hospitalization, and reduction improvement in survival. So this is a novel agent which is highly selective. It has very rapid onset. Within 1 hour it acts. It works even in dialyzed patient. It is guideline recommended, and there are no significant drug-to-drug interaction. Generally, 1 sachet is enough. Maximum dose is 2 sachets TID. And in the maintenance dose, just 5 grams per day, you can even use it for up to 1 year. You have to dilute it with 45 ml of water. And you can see that this drug helps in hyperkalemia, which is often recurrent and an ongoing threat, which has been associated with increased risk of mortality and hospitalization in cardiorenal patients, which are not uncommon. End-stage heart failure, cardiac patients becomes a cardiorenal patient. So for rapid potassium correction and to sustain potassium control, using sodium zirconium really helps and can enable guideline-directed therapy, and majority of patients who were treated with this agent were able to continue their RAS therapy. So the data is continuing to come with a new trial which is going on called Crystallized Evidence Program. Thank you.
Thank you, ma'am. That was a great talk with a lot of insights. We have with us Dr. A.K. Pancholia, who has written way back in 2018 a chapter on newer anti-hyperkalemic drugs. Over to you, sir, for more insights.
Being a sodium salt, what are the chances of hypertension and pedal edema?
Generally, it is not absorbable, sir. So it doesn't get absorbed. It just gets completely excreted. So sodium doesn't affect.
Yes, and you not discuss the peritromer. You not discuss the peritromer.
Sir, I had put it in the comparative slides.
Because in the several studies, peritromer was used much more as compared to sodium zirconium.
I had put it in the comparison slides.
Excellent lecture.
Thank you.
In fact, I got a lot of insight. I have some patients, Dr. Jakia, very elderly patients, my friend's father and all, and they have no heart failure, just hypertension. I took off all the, ARBs and all, and given very low potassium diet, but still the potassium is high, and they have relative bradycardia without any reason. So in that situation, now I am thinking, after your lecture, that it could be an extended use. And is there any evidence for that, or I just...
So the use has been for even normal population, and you can use it even for up to a year. So it's a long-term use drug. Yeah. So 5 grams sachet daily.
Yes. Yeah. Low dose I can start without any problem. They are otherwise not.
No
LFT changes.
Nothing, sir. Ma'am, it doesn't get absorbed systemically.
Thank you, sir.
Yeah. Ma'am, this Patiroma has the advantage of improving the calcium and reducing the phosphates, especially in CKD patients. What is the impact on calcium?
Patiroma may be better in CKD patients where there is a... But if you want to acutely bring down potassium, this is one of the best drugs, and even for long-term usage.
Thank you so much.
Patiroma, I think, is more expensive also.
More expensive.
And not very easily available.
Yes, ma'am. That's the main drawback of Patiroma. Yes, ma'am. Thank you so much, ma'am. Thank you. That was a great talk. Now we move on to the next talk by Dr. Poonam Malhotra. Spotlight lecture, ECMO current status when crashes are cannulated. Over to you, ma'am.
Thank you, Vinkars. It's been a pleasure coming here year after year, and second time to Indore, and a big hearty thank you to the entire team. Having been a co-founder helping with the journal, I feel very happy the journal today is Scopus Index, doing so well. And we at AIMS, and that's AIMS, which started, I've been there for 28 years, and I feel happy I've been a co-founder for the ECMO team in 2002. No looking back, we do so many VA ECMOs, but here we're talking of heart failure, and why when a cardiac arrest happens in a cardiac failure patients, why is there so much of mortality, and why does it harm every patient worldwide, not just in India? So out of hospital or an in-hospital cardiac arrest needs to be cannulated, and ECMO in the last 5-6 years has emerged as a rescue therapy in refractory cardiac index arrest. Emergency ECMO cannulation during cardiac arrest is a big enigma. It's a challenge. Why? Because when you have a cardiac arrest, conventional CPR is what the Indian population at the layside, on the roadside, in a road traffic accident, even amongst the medicos, is used to. How many of us think of ECMO cannulation? And it's very easy. It's used when ECMO CPR fails, and the goal always is to have a rapid restoration of the systemic circulation. So when you have an arrest happening like this and there's a paradoxical breathing, eCPR, the VA ECMO, is very, very easy. It's a sleek machine today on a trolley, on a stand, which can be primed and kept in the emergency ward, in the casualty, as well as in the cardiac unit of the cath lab or the CCU. Burden of cardiac arrest has increased so much, and therefore, when patient is in low cardiac output with poor cerebral perfusion, metabolic acidosis, along with high mortality and prolonged CPR, this conventional CPR, when it is failing, it is time within the first 30 minutes to put onto ECMO, because ECMO works as a machine that provides systemic perfusion. It maintains the oxygenation. It restores the coronary perfusion as well as bridges the gap to definitive therapy. While we are waiting, it is an excellent bridge to recovery or a bridge to transplant, but we should not put it for ethical reasons, for financial gains of the institutions, because as early as 1970s, when experimental eCPR was coming, and in 2000s, when ECMO programs of eCPR, particularly in Czechoslovakia, Prague, where we've seen cardiologists perform eCPR very, very well. It picked up in Qatar, it picked up in Saudi. These are health policies of the government of those countries today. So in a voluminous country like ours, where road traffic accidents are so much common and so is heart failure, I think eCPR team is mandatory in every emergency, and that should be our next healthcare norm. Patient selection should be very nicely chosen. A witness arrest, whether in the hospital or outside, with a very short no-flow time, age less than 70 years, potentially reversible cause is where we would like to put an ECMO, particularly in an acute cardiac myocardial syndrome with heart failure, massive pulmonary embolism, myocarditis, all of them leading to heart failure. Never put it when you have a prolonged CPR which is going on for more than half an hour, severe comorbid illness like a cancer, or an advanced age beyond 70 years. Do you keep prime circuit? This was a survey we all did from the ECMO Society of India. And do we keep prime circuits ready in anticipation of eCPR around the clock? Well, in India, there are today 129 ECMO centers, and of those, 25 are recognized by the ELSO. Of these 25, 18 of them are doing only VV ECMO, and all of their centers have, they're all private centers, most of them, most of their centers, including RVCC Mumbai, the Fortis Gurgaon in Gurgaon, as well as many other centers I can name where ECMO circuits are kept prime. How much is the time taken for ECMO team to arrive to initiate eCPR in your center is something which is, again, a hospital policy and administration policy. It should ideally be never more than 30 minutes, within 10 to 15 minutes. So there are challenges. ECMO today is showing a survival. This is a very recent ELSO survey of only 70%, I mean, it was 30% survival. Now it is 70% with 30% mortality. Today, when we talk of ELSO and we talk of outcomes, we're seeing better outcomes in non-cardiac centers as well. The ECMO centers are rising around the world, and centers by centers, the incidence of ECMO is rising. But as the Global Life Support Organization, particularly in differing parameters like Africa, Asia, as well as India, continues to rise, what does not happen and what does not change is the acceptability of communication that this patient needs eCPR. So conventional CPR to eCPR should be a medical lingo in every textbook of MBBS as well. That's what the ELSO is coming up with. Because in many people's mindset, ECMO is this busier OT. No. ECMO today is a very, very sleek thing. We do a lot of simulation-based training of ECMO to our students when they come in the first year of DM cardiac anesthesia or DM cardiac surgical intensive care. Which device is to be used? An IBP, a VA ECMO, a percutaneous VAD, or a temporary VAD should be known to all in coronary heart failure and chronic heart failure patients. ECMO should judiciously be used as a bridge to recovery and a destination therapy, awaiting a VAD, awaiting a transplant. VV and VA ECMO are the two types of ECMO. For a bad lung and a good heart, it's always good to have a VV ECMO. But in a bad heart and a bad lung, or even a bad heart with a good lung, VA ECMO, whether peripheral or central, is the norm. What is the backbone of an ECMO? Is the team. The backbone is the team of perfusionists, nurses, the intensivists, the cardiologist who's given the patient, as well as the surgeon who's cannulated. At the end would always be the airway manager, the anesthesiologist. Oxygenator, this you see is our team. Oxygenator is a CardioHelp today, very advanced mecha machine, which has very nicely stacked PMPA silicated parameters. It's a 3-compartment chamber here. You see one where the blood from the patient, which is rich in carbon dioxide, mixes with the air from the pipeline. And the second is where the gas exchange takes place. And the third is where all the carbon dioxide is removed by the sweep gas, and you get only pure oxygenated blood back to the patient in about, I'll just take a minute more. So when you are knowing the contraindications and knowing the cannulations, the Seldinger technique is what we cannulate it by. And while we are cannulating it by the Seldinger technique, the configurations for access and return cannula, the access cannula, the drainage cannula is always from the RA, the femoral vein, the subclavian vein, or the internal jugular vein of the patient into the ECMO machine and returning to the aorta, femoral artery, axillary artery, and carotid. Crash to cannulation, as I said earlier, should maintain the cerebral perfusion. Troubleshooting of the ECMO pump giving way, LV distension happening. This LV distension worsening the heart failure, and echocardiography bringing about very good results. Aortic valve opening is what we see, and how to wean the patient off is what we do. What do we do at AIMS? We do integrated ECMO. We use bivalirudine instead of heparin to decrease the amount of bleeding. While we are using bivalirudine, which has a short half-life, we have these algorithms so that our patients on ECMO do not bleed. The heart failure is so well after the LV is unloaded, and then this patient is bridged to transplant or bridged to recovery. So wherever we are and whatever we are doing, establishing and sustaining an eCPR program is a very alternative therapy today to the intensivist and the cardiologist. We have a Make in India by the Allied Sciences defibrillator, which is housed in all ICUs and our OTs today. We've done away with the Philips monitor and the defib. I think we are in for an Allied Sciences giving us our first AID for these patients. So managing a patient on ECMO requires a thorough understanding of normal and abnormal cardiopulmonary physiology. It is very doable today to have an ECMO in the emergency or in the cath lab for a heart failure patient. With the ability and understanding of ECMO, we can manage severe respiratory and cardiac failure. This is the journal which we take out. I think it's stopped there. And I would like to thank Vincas again. Any questions on ECMO, I'll be happy to take.
Thank you so much, ma'am, for the elusive talk. Over to our expert chairpersons and panelists.
Hi, very nice talk, Poonam. Just wanted to know how many cases of ECMO have been used for heart failure at your center?
Ma'am, actually ours is a pediatric cardiac surgical center, as you know. You're a brick in the wall of that center, contributed so much. But we do VA ECMO integrated even in heart failure patients who are pediatric. We do integrated ECMO where I know an L-Kappa or a TGA or a Norwood is not going to come off bypass and then will be in low cardiac output. Instead of those inotropes going, we come off on the ECMO circuit, support that weak heart for 5, 6, up to 18 hours on ECMO and then fall off. One heart failure is the pediatric heart failure. The other is the crashes in the cath lab. So cardiogenic shock in the cath lab, in a redo fountain sometimes, in pediatric patients, in adults coming with any kind of myocarditis. Only about 8-10 days back, we had a myocarditis young man, 18 years, and he came to the emergency, and he was one of the cardiologists in the emergency, a very senior person, referred him for stenting or something in the cath lab because he thought probably he needs something more to support to his heart. We as a team went down, put the ECMO in the cath lab, got him up, and he was put in the CCU, ICU A for some time, for about 18-20 hours, and then shifted to the CCU. 4th day, weaned off. So we do have patients, and pediatric patients more than, we are doing only VA ECMO. VV ECMO is done by the pulmonary medicine people today, but post-COVID, before that we did do VV ECMO, and VV ECMO you don't need for cardiac failure. But in ECPR that you do on the roadside or in the emergency, to every MBBS student who's even posted there as a JR, it's easy to cannulate the peripheral femoral vein and the peripheral femoral artery. So peripheral VV ECMO or a peripheral VA ECMO in heart failure is done in the emergency or cath lab. Cardiologists do it better than any intensivist. But by the time they reach the ICU, I think heart failure is in. What we need at AIMS is a good ECPR program. We need to rethink about our setup.
Thank you.
Just a small question from my side, For an interventional cardiologist, the biggest nightmare is a large anterior wall infarction coming pulseless. But there is no data which has shown that using ECMO improves their mortality. Only
There is
Impella is, if at all, shown some improvement.
There is data. If you see the Prague registry and the also ECPR registry, there is very good data to show that the mortality is very high. I mean, the survival is only about 28 to 30% in these pulseless cardiogenic shock patients succumbing during PCI in the cath lab. But this data is very robust. Today, with the availability of an Impella, CP or RP, whatever we are using, the Western population resorts first to that. It's as easy to put as an ECMO cannula. What deters the use of ECMO is the bleeding complication, and in our Indian scenario, sepsis. And sepsis in the pediatric patient, because of the protoplasm of it being hypoalbuminemic, can easily be cured with good nutrition.
So maybe more bleeding risk increases.
Deters us because of the bleeding, because we use heparin.
MIs will require a lot of blood thinners.
Because we use heparin, but let's say your patient is on TPA, your patient is already on D-plat. This patient may just be on low molecular weight heparin to put an ECMO. That's all. The heparin alternatives are in today.
Thank you.
Yes.
Maybe Dr. Jakia, in the cath lab, what we do is in a reflex when we are revascularizing and patient is not improving with the highest inotropes, we first put the IABP.
Yeah, that's what we do.
It really
that's what we always do.
It really rescues. Then we call the.
That's what we always do. But
ECMO team is there.
sometimes the patient needs
Yeah,
more than IABP.
Ma'am, you go to Global Hospital, Kim Hospital today, all of them are first putting ECMOs. We still put IABP, as ma'am is saying. IABP is kept ready, but we also have primed ECMO circuits in our ICU outside. And today we have 5 machines from Mecca that have come in.
ECMO
and I
is
think
cheaper also, right?
Much
Compared
cheaper.
to Impella,
Much
ECMO
cheaper.
is
Much cheaper.
Yeah.
Yes, sir.
Thank you so much for giving such a overview and making ECMO sound feasible, possible, and not financially such a huge burden as has always been thought of. Like my first experience with ECMO has been from 91 when we were initially at the Royal Children's Hospital. So, of course, there have been such big success stories. At that point of time, of course, there was this clause where there was 80% likelihood of not making it, and therefore there would be the inclusion. And from the point of view of eCPR, which you are now advocating, how would you choose whether it's going to be VV versus VA? How would you
If-
decide?
if
Because
you-
the veins, there'll be no pulse here. I mean, the patient is not going to be
If
easily.
there's no pulse, it's always a first a VV. You can convert the VV to a VVA.
Once
So it's
things-
easy. So let's say you get the history of the patient. It may be a case of poisoning, okay, which is leading to the heart failure. But let's say you've had a cardiac arrest outside the hospital. You've got him to the casualty and you've put in a VV ECMO. It's very easy to convert that VV, one peripheral vein, IJV, one femoral vein, into a VVA by cannulating another femoral artery and converting that VV ECMO through another cannula into a VVA for some time, and then later removing the bridge and making it a VA.
Fine.
It's very easy. There are lovely cannulas, lovely tubings, and very nice connectors available today. Your only thing should be who should do it,
Right.
only an expert, and when should it be done. Never in the night, which most perfusionists want to do.
Oh. Cost-wise, who bears the cost? Because sometimes it's a
In a public
roadside-
sector like
public sector.
like AIMS, it's 1 lakh per ECMO for the first 10 days and another 50,000 for the next 10 days. So we are very lucky, we
I
are
mean,
government aided.
this is-
But in a hospital, which is a corporate hospital without naming them, it is 1 lakh per day in an ICU, and the patient's relatives or the insurance of the patient pays for it.
Insurance pays, right? Okay.
It is sad. It is sad. So that's why we should make our own India make, so that we don't have to import these oxygenators. And I just want to say that with a lot of training and research, our WCC ECMO Society of India from Bombay is ready to first launch its oxygenator end of May this year.
That's
Just
great,
like-
ma'am.
just
But
last-
due to one,
Okay, last, their neuro outcomes. That's the most important, and I think they're good, I hope.
thank you, ma'am. Thank you. That was an elaborate and very good discussion. We now move on to the fourth topic of today's session. Dr. Aditi Singhvi, gender differences in heart transplantation. Where do hearts really go? Over to you, ma'am.
Good morning, everyone, and thank you to the organizing committee for inviting me to speak on this topic. This is something that I'm very passionate about, and it's really nice that I'm getting this opportunity to discuss this topic with everyone present here. So, shifting to another form of advanced therapy, from ECMO now to heart transplantation. So, we'll go over what are the current disparities in heart transplant access for women, and review gender differences in pre-transplant characteristics, examine the post-transplant outcomes and complications by gender, and then lastly, identify strategies to improve equity in transplant care. So why is this important? There is a huge gender gap in heart transplantation. Women are less likely to be referred to an advanced heart failure specialist for evaluation of advanced therapies. Even though women account for almost half of the heart failure deaths, only about 1/3 of the candidates or 1/4 of the candidates, 25 to 30% of heart transplant candidates are women, and same with durable LVADs, only about 20% of LVAD recipients are women. And this disparity has persisted for many years. Now, much of this data is from the Western world. Data in our setting regarding transplant is limited to mostly some single center data, but essentially the data over here from single centers is also similar. So starting from pre-transplant characteristics, right from the etiology, there are differences between women and men. Women are more likely to have non-ischemic cardiomyopathy, restrictive cardiomyopathy, valvular heart disease, particularly in a country like India where rheumatic heart disease is very common, and women are more likely to have rheumatic heart disease. Then cancer therapy related cardiac dysfunction. These are the more common causes of cardiomyopathy in women. And compared to men, who are more likely to have ischemic cardiomyopathy, though now there is a large increasing burden of ischemic cardiomyopathy within women as well. So it is possible that these different etiologies contribute to a different trajectory towards advanced heart failure, and this can influence timing and their perceived suitability for transplant. For example, non-ischemic cardiomyopathy, restrictive cardiomyopathy, cancer therapy-related cardiovascular dysfunction are more likely to involve the right ventricle also. So typically these women present with severe biventricular dysfunction compared to ischemic cardiomyopathy, which is predominantly left-sided. Next, coming to barriers of transplantation. There are several of these, starting from the basics, which is under recognition of advanced heart failure symptoms. Women are more likely to have their symptoms dismissed as psychosomatic or related to sleep disturbances, related to family issues, personal issues, those kind of things. So it starts right from the basics. Then much lower referral rate to advanced heart failure specialists for considering advanced therapies. Only about 25 to 30% of referred patients are women, even though we know that about half the patients who are suffering from heart failure are women. Now, even the ones who are referred, they are often referred late. So there are delays in access and delays in getting referrals. And probably as a result of the delays, as well as because of the differences in etiology, women are more likely to have end organ dysfunction, liver dysfunction, renal dysfunction, which can also be a hindrance to listing for heart transplant. Women are more likely to bear caregiving responsibilities. So that also creates a bias in the provider's mind whether these patients will be suitable candidates because they have parents or children to look after. And there is an implicit bias in provider decision making. There has actually been a survey done where the identical clinical vignettes were presented to multiple physicians, and they were more likely to think that social support is adequate if the patient was a man compared to if the patient was a woman. Then there are higher rates of allosensitization in women, and a lot of frailty assessment is subjective rather than objective, and women, because of smaller frames, smaller muscle mass, are presumed to be frail. So this is data showing why women were not referred for heart transplant or MCS, and predominantly the reasons are either the patient was too sick or psychosocial. But if we use objective measures of psychosocial assessment like the PSIPAT score, over here it's not very clear, but essentially these are black females, black men, white females, white men, and we can see that objectively the PSIPAT score for all these patients are similar, which means if we use objective measures, this is probably not real, this is an implicit bias that is there. Also importantly, females are less likely to have their spouse as a caregiver, only about 40% of them, compared to males where 70% had their spouse as the primary caregiver. Now, allosensitization. This is a female-specific challenge because women develop anti-HLA antibodies through pregnancy, blood transfusions, or previous organ transplantation. Main risk is pregnancy. So this can make it more challenging for women to receive an organ as well. If you look at waitlist outcomes by gender, this is data from the US. So women who had the highest priority status, the emergency status, that is status 1, they had significantly worse outcomes. So shown here in red are men and women in blue. Men were more likely to get transplanted, and women were more likely to die on the wait list if they were emergency status. In routine status, that is status 2, that difference was not there. Possibly this is as a result of allosensitization, and also temporary mechanical support is much less likely to be considered for women in cardiogenic shock. So these are some of the reasons, but even after correcting for this, this doesn't explain the entire picture for why women have a worse survival on the wait list. So coming to clinical status at transplant, women are more likely to be more critically ill at the time of transplant with worse renal function, and there is lesser usage of temporary mechanical support in women. This might be because of their smaller vasculature, increased risk for complications, increased risk for bleeding. Next, coming to donor heart acceptance patterns. Historically, female donor to male recipient was thought to be a risk factor for primary graft dysfunction, but now with using predicted heart mass ratio, that is no longer the case. So as long as the heart size is well matched, female donor to male recipient also has equally good outcomes. So perioperative outcomes in women versus men. There is some data that suggests that there may be a higher degree of primary graft dysfunction in women, but that has really not borne out. So sex is not considered a risk factor for PGD. And further mechanistic clinical studies of sex differences in PGD are needed to really study early post-transplant outcomes. Now, if you look at sex-specific outcomes post-transplant, here we see that recipient sex, overall long-term survival, looking female versus male, is similar between genders. There is similar 30-day mortality, similar 1 year and 5 year survival. So women do as well as men if they get a transplant. So there should not be a deterrent if the patient is a female to refer them for transplant. Coming to immunosuppression, there are no gender-specific studies really, but this is just extrapolating data subgroup analyses from studies done on induction agents like ATG, and possibly it is thought that there is more benefit in women compared to men. Now this is important because the guidelines look at the overall data and not really sex-specific data. So women might be getting under-immunosuppressed and probably might be deprived from therapies that might benefit them. There might be different responses to immunosuppressive agents also in women, and they are more likely to have pre-existing anti-HLA bodies that require desensitization. Is the effect of desensitization different in men versus women? We do not know that, and more studies are needed. So these are some of the major landmark studies of immunosuppression in transplant recipients, and we can see that most of these studies only included about 20 to 30% of women. So really we don't have enough information to say if immunosuppression behaves differently, responds differently in women. Coming to complications based on gender, women are more likely to have acute rejection and renal dysfunction, while post-transplant malignancy and cardiac allograft vasculopathy is more common in women. So just quickly, I'll finish in the next minute or so. Women do have more rejection episodes, increased hospitalization for rejection, and primary cause of early mortality in women post-transplant. But some of the non-invasive surveillance that we have for rejection, like donor-derived cell-free DNA, gene expression profiling, these seem to have similar values in quiescence as well as rejection. It's playing automatically. Okay. So lastly, I'll just present our experience. That is, in the last 4 years, we have listed 89 patients for transplant, and majority have been men, 71 compared to 18 females. 18% men died on the wait list compared to 33% women. And if you look at post-transplant outcomes, though, it was similar in both men and women. So this is heartening to see that, and future research is needed to investigate some of the differences that we're seeing. My key takeaways are that there is significant underrepresentation of women in heart transplant. Multiple barriers are present that require holistic solutions, and gender-specific pathways are needed to improve outcomes.
Thank you. Thank you, Dr. Aditi, for the excellent talk. Any questions from our esteemed chairpersons or panelists? Due to want of time, I think we'll conclude this session. Thank you so much, Dr. Aditi. I thank all the 4 legendary speakers, esteemed panelists, and chairpersons. Thank you so much. We now move on to the next cardio-obstetric interesting session.
Thank you so much, ma'am. I'd like to request our honorable chairpersons, panelists, and our moderator to kindly proceed for the felicitation at the presentation wall. Ma'am, please. Ladies and gentlemen. Ma'am, at the presentation wall, please. Ladies and gentlemen, it's time to move on to our next segment of talks, which is Indian Cardio-Obstetric Blueprint, Bridging Guidelines and Grassroots. And to chair the sessions, I'd like to invite Dr. I.B. Vijayalakshmi, Dr. Pradeep Kumar Gupta, Dr. Rajeshwari Nayak, Dr. Archana Sathe, and Dr. Archana Dubey. In the expert panel, I'd like to invite Dr. Meera Govindarajan, Dr. Vasudatta Sharma, and Dr. Madhuri Nagori. And to moderate the session, I'd like to invite Dr. Sanjukta Bose ma'am. Ladies and gentlemen, can we have a huge round of applause for our chairpersons, panelists, and moderators? Now it's time to invite our speaker to begin this segment. Please welcome everyone, Dr. Chhabi Satpathy, who will be talking about PIH to preeclampsia, why the Indian phenotype is different. Ladies and gentlemen, please welcome our honorable speaker, Dr. Chhabi Satpathy.
Dr. Chhabi, are you there? Okay, we can go to the second
Chhabi is not
talk.
Yeah, sure. For the next talk, I'd like to invite Dr. Justin Paul to talk about interventional rescue in the second trimester, mastering structural interventions for the Indian Queen. Ladies and gentlemen, please welcome our speaker with a round of applause.
Good morning, gentlemen and gentlewomen. So it's such a joy and privilege to be invited by Vincas to be with you, to share something on what we can do for the Indian queens. So salam and salute to all the queens gathered here. So the topic is mastering structural interventions in the second trimester for the Indian queen. So should we do it? If so, when should we do it? And how should we do it is what we'll look at it. To start with, we'll talk with the Indian married queen. She was 25 years pregnant, 25 weeks, shortness of breath, NOHA class 3 and 4 for the last 1 day, referred from a center. You can see that she has a diastolic murmur and she is in pulmonary edema. So they shifted for echo and they found that she has significant mitral stenosis and she was balloonable. So the resident was happy. And, if you look at mitral stenosis in pregnancy, mild is generally tolerated well. Significant MS, when it is less than 1.5, almost a third of them develop heart failure. And critical MS less than 1.0, almost half of them develop heart failure. It is so common in the second trimester, which is what we are looking at. So, and in our own data of 145 patients significant MS, we find that almost these women are 2.5 times more likely to develop heart failure and fetal, adverse outcomes compared to the rest of the people. So she was managed by a queen of Lucknow. She has not come today, Rupali. And this is a part of the NPAC India study at Lucknow. And they decided to do a balloon valvotomy for this patient. So they called for a multidisciplinary counseling and there enters the king. How long she has been having this disease? Did she have it before the marriage? The mother-in-law comes, they have cheated my son. Now this is the kind of issues we always happen. We need to face it if you're doing cardiac interventions in pregnancy. If you're dealing pregnant women with heart disease, you have to negotiate very nicely. And they could show our data. MPAC data, which shows 1,029 pregnancies, of which 50% were diagnosed for the first time during pregnancy. The guy was an educated guy. It was shown to him online. You download and find out. So your wife is not cheating you. This is what is happening in India. So finally, they are together. They have a nice baby. Now, so they did the balloon mitral. I don't have to tell you about how to do a balloon mitral valvotomy in pregnancy. I mean, routinely, you're all doing very well. But then there are some minor adaptations we always do. This patient had a successful procedure. The baby delivered well. This is our earlier data, where of the 50 patients, we found that we underdilated and the 1 year results restenosis rate was quite low. So if at all you do it, when do you do it? We need to balance a couple of things, the fetal radiation risk and the fetal survival in case of a premature delivery triggered during the interventions, and the procedural ease of navigating the hardwares through the groin, particularly when the pregnancy is advanced, and the mother's ability to tolerate the disease till such time. So bringing all these together, you need to decide when you want to do it. Now, always after 20 weeks of pregnancy, and it is preferable after 24 weeks, and we prefer to do it around 26 to 28 weeks. After 30 weeks, we have done a couple of cases, 32, 33, but then, sometimes taking the hardware over the gravity uterus, under the gravity uterus may be a little difficult. So, use echocardiography as much as possible, and all the radiation safety norms, please use it. Try to use suboptimal dilatation. We usually go 1 to 1.5 millimeters less than derived by the Hung's formula. A valve area of 1.3 plus is good and sufficient, or even a 25% greater increase is always better. Better is the enemy of good, whatever you can say that. So if you want to get I would like to give a 2 valve area, and if you develop an MR, then it is going to be a greater difficulty. You can always call the patient 6 months or 7, 9 months after delivery and do another balloon if really necessary. So this is our data from the NPAC India study. For those of you who do not know, this is a national pregnancy and cardiovascular disease study of India happening in 56 sites in the country, and we have enrolled 5,400 participants, and very soon is going to be the single largest study of pregnant women with heart disease in India. And many of you are active members, and Anita ma'am is our advisor. We have done 104 procedures from 20 sites. As you can see that if you're looking at treating a pregnant Indian woman, the most common procedure that you're going to do is balloon mitral valvotomy. Maybe followed by balloon pulmonary valvotomy. We had a couple of coed stents and 1 balloon aortic valvotomy. So you look at that, 33 were done as emergency procedures and 71 as elective procedures. Majority had good success. There were 2 maternal deaths. 2 maternal deaths that could also include fetal deaths. So it is a very, very painful thing, but these women came in the last moment, and they came in pulmonary edema. The doctors did their best, but they could not salvage. 3 patients went for emergency surgery. If you look at the common indications for interventions, if you look at the MWH 3 and 4 category, the severe symptomatic MS, moderate and severe mitral stenosis, and maybe coactation. These are some of the common things that we may face in India. Now coming to aortic stenosis in pregnancy, this Indian lady, Queen I'll call it, was treated by the Queen of Madurai. I think she is here. Selvarani, Dr. Professor Selvarani, yeah, she's here. So, Rani Mangamma. This picture is of Rani Mangamma, but then Rani Mangamma is not there. Dr. Selvarani is there in Madurai. So she was treated by Dr. Selvarani. The previous queen I gave was the Queen of Lucknow, and Rupali had done that. So since the topic was given to me as Queen of Indian Queen, I thought I'll bring in some queens. So this lady, she was symptomatic, and they found that this is a suitable case for balloon aortic valvotomy. Now, what do you do with a patient with aortic stenosis during pregnancy? If the patient is asymptomatic, severe aortic stenosis with normal LV, they will go through pregnancy smoothly. Please do not intervene. Just verify that they are really asymptomatic. And if she is symptomatic with the normal LV, mild symptoms, try to manage the symptoms medically. If she has reduced LV function or symptoms are not responding, then is where the difficulty comes, where you may have to do a balloon aortic valvotomy, if suitable. And if it is not still responding to balloon aortic valvotomy, surgery around 28 to 32 weeks, depending on the center's expertise. It will be always good if centers develop expertise to manage a cesarean as well as valve replacement around 30 weeks. A couple of centers in our country are doing it. I wish more and more centers start working on this, because we do have a lot of patients who come into this area. Not only just this, but then severe mitral stenosis with mitral regurgitation. In fact, we recently did a patient with the moderate plus mitral regurgitation with a critical MS, and we found that the MR was not from the commissions, was from the center. So we planned and did an underdilatation. We had a good opening of the mitral valve, and MR became severe, but patient tolerated the procedure well. And the severe symptoms, TRPG was 120. It had now become 60, and she is planning pregnancy. So this is what they had done in Madurai, and the patient survived. So a few tips. It's always retrograde is better. And a long sheath position before the left subclavian artery facilitates catheter exchange and reduces radiation instead of the usual short tips. That is something that we can do. And start with 2 to 3 millimeter less than the annular size. And if a little MR develops, you please abort the procedure. Femoral closure device is always good. TAVR, a couple of cases, a dozen cases maybe have been reported, but then lifelong management of aortic valve is very, very important. We have to be very, very careful about this. And pulmonary stenosis, we had, I think, 4 pulmonary stenosis, balloon pulmonary valvotomy, done in our patients. But I would like to tell you that severe PS with the normal right ventricular function, they tolerate pregnancy very well. 120, 130 gradient, they tolerate very well. And you don't really have to rush in. But if the patient is symptomatic, if the patient has RV dysfunction, then you may have to intervene, or the patient has RV failure. So this was one patient from NPAC India study at AIMS Bathinda. Bhupender, our good friend, had done that. And as you can see that the patient was planned, they waited, but then she crashed during LSCS. She was shifted after the LSCS to cath lab the same day, same hour, and they did a balloon and the patient survived. This was another patient from KEM Mumbai, our friends Ajay and Charan Longiver had done. This patient had a middle aortic syndrome. Yeah, I'll finish up in 57 seconds. They had done a stent. So this is just to give you a profile of what kind of patients we have done in India in the last 1 year. And maybe the last patient I'll show you is from our PJ and Raipur, Dr. Smith Srivatsava and team. This patient had a STEMI. A STEMI during pregnancy is not always scared. It's about 30 to 40% scared, and a significant number of time it is atherosclerosis as well. So it's always safer to do an angiogram, and in fact the current recommendations do not differentiate STEMI during pregnancy compared to the STEMI not during pregnancy. So this patient did well, and so to summarize the indications of pregnancy, cardiac interventions during pregnancy is, these are some of the indications. You know them well, we have discussed this. So please ensure that mild to moderate stenosis, they do well, you don't have to interfere. Severe asymptomatic diseases also do well. And cardiac interventions are less often needed during pregnancy. Good to always involve senior experienced operators. A cardio-obstetric team approach is very important. And all these 3 registries that, that has given us a lot of data, starting from a single center impact registry to 29-site Tamil Nadu registry and a 56-site national registry. I thank all the investigators and all the members of these sites who have collectively gathered all these data. Thank you so much for this opportunity.
Excellent presentation, sir. Can I ask all the esteemed chairpersons?
Very
for a
lucid
good
presentation. Just anecdotal incidents. A chondroplasia patient with 178 gradient across aortic valve. The anesthetist was not ready to give anesthesia. Then the obstetrician was not able to do the cesarean, so they referred. And she didn't have money, poor lady, so obstetrician and myself, we both donated, and I did the balloon dilatation, and then she developed pain and referred. Then she underwent. Beautiful baby, she came and showed to all of us, and we were so thrilled. And then she never came for 1.5 years. She came only when she became pregnant again. So that's how our patients are.
It's a common scenario of India.
Another patient, just 0.4 square centimeter, full-term pregnancy, apoplexy, almost half a liter of blood she was losing. We did the emergency, and after that we went on telling the obstetricians to refer in time so that, that doesn't happen. And you said the mother-in-law complaining. So I have the other way around. A husband brought the wife for the fetal echocardiography.
That's
nice. The moment he saw me, he was so thrilled and he started jumping. I said, what's the matter? You are the one who has closed the AST in my wife, he said. I said, but how do you know when I have closed at 5 years of age? How will you know? No, before marriage, my father-in-law showed your picture and he said, she is the one who has done. You can go and ask, she's normal. And that's how I know. The things are different. Not
Yes,
that
madam.
always they
Exactly.
blame. They can
Very,
give
very
compliment
important message,
also.
I think, madam. Thing is the teamwork, as you highlighted, the obstetricians, the cardiologists, when they both join together to treat the patient, the results are invariably good. Number 2 is that the counseling and the contraception to be given to the patient always after this kind of procedures. And number 3 is that India, of course, queens and kings are getting together well. So happy to know that.
Sir, I just want to know, this pulmonary
sir.
stenosis patient, why he did not undergo intervention?
Madam, this patient, Dr. Rajeshwari, thanks for the question. This patient was minimally symptomatic, and she came for the first time antenatal registration at 37 weeks. So they didn't really want to do the balloon. They said, okay, we'll do the LSCS and then plan.
Just one simple question. So because of the fact that we have got now currently more overweight women who are also going in for becoming pregnant, not simply from the pulmonary or from general body edema. So do you decide indexing to obviously which for the severity, do you make that little adjustment from that point of view?
You are right, madam. I think what madam talks about is, say, for traditionally in India, when we say severe MS, it is 1.0 minus, and moderate is 1 to 1.5. If we look at the Western guidelines, it's always less than 1.5 is severe. And it is predominantly to the fact that their body habitus is slightly larger. But then again, in an Indian study, when we published the MPAC, I was trying to look at less than 1.0, less than or equal to 1.0, less than 1.5, less than or equal to 1.5. Found that less than or equal to 1.5 itself was, increasing the outcome. So and it is always wiser, as you said that, madam, in a 1.0 valve area in a 50 kg lady, and it's definitely different from a 100 kg lady.
Thank you very much, Dr. Justin. You are always a proactive person for the women care and especially the queens. And now we move on to the next speaker, Dr. Satyanarayan Rautri. Please give a big hand to Justin. Yeah.
Ma'am, Dr. Geeta will be coming up next. Dr. Satyanarayan is not there.
He's not there?
No, so Dr.
Then
Geeta
I think
will be
we
coming,
can
right?
take more question for Justin. Sir, sir, please stay here, sir. At the
Dr.
end,
G.
we'll have
Silvarani. Please, can we have her on stage?
Yeah.
She'll be discussing a very important
Selvarani
topic.
is not? Selvarani. Yeah, we will invite Dr. Selvarani, following the Queen and of Madurai. She's going to speak about the decoding the red flags and risk stratification for heart diseases in pregnancy. Selvarani, please.
Very good morning, respected chairpersons and my dear friends. I am really privileged to be here, and I thank the organizing team for having given me this wonderful opportunity. I am Dr. Selvarani, HOD Professor of Cardiology, Madurai Medical College, Tamil Nadu. And I am going to talk on the decoding red flags and risk stratification in heart disease during pregnancy. Decoding red flags means what are all the red flags and how we have to interpret like that. So this is the introduction, and the burden of cardiovascular disease in pregnancy varies from 1 to 4%. You know very well the physiological changes. And this is a global burden, and peculiar to India is the rheumatic heart diseases, followed by cardiomyopathy, pulmonary hypertension, etc. And the Indian scenario, as I have told, rheumatic heart disease tops the list, out of which mitral stenosis tops the list. And this is because of the late diagnosis during the pregnancy. Very common social problems we have already discussed. And this is the physiological changes. You know very well, there is an increase in the cardiac output, volume, rate, which is like a stress test for the female. So these are all the types of heart diseases, congenital, acquired heart diseases. In the congenital, ASD is the most common, and in the rheumatic, mitral stenosis is most common. In the cardiomyopathy, DCM is most common. Ischemic heart disease is very rare. And relatively, maternal mortality risk is very high when the patient is having pulmonary hypertension, and followed by cardiomyopathy, followed by valvular. And maternal cardiac complications are heart failure, decompensation, pulmonary edema, arrhythmia, AF, ventricular, thromboembolic manifestations, myocardial ischemia. This may occur in the high-risk patients. Stroke can occur in the mechanical valve patients. Maternal complications often occur in the late pregnancy. It is very important for us to go for a risk stratification. Who will go for a high risk, who will go for a low risk, and anesthetic complications, delivery complications, post-operative and puerperal complication. Everyone we have to be thorough. And coming to the risk stratification models, we have already modified WHO classification, the 2.0 classification, CARPREG score, CARPREG 2 score, Sahara score, and this is recently updated by ESE guidelines. And this is the modified WHO statement. The class 1 represent no significant increase in the risk. Class 2 represent small risk. Next will be the intermediate, next will be the increased risk, and very high risk is the fourth stage, and pregnancy is contraindicated in class 4 conditions. I want to read out the class 4, maybe it's a repetition. The Cardiology score can be used in which the points are given for events. Prior cardiac event 3, baseline NYHA class 3 and 4 with cyanosis 3, mechanical valve means 3, ventricular dysfunction is 2, high risk left-sided valve diseases, left ventricular outflow tract obstruction is 2, pulmonary hypertension 2, CAD 2, high risk iotopathy 2, no prior cardiac intervention 1, and late pregnancy assessment 1. So among which more than 4 points the death rate is 41%. That is why we are going for scoring system. And Zagara score is also there, and here Zagara score prior arrhythmia 1.5, cardiac medications before pregnancy 1.5, NYHA more than 2.75, left heart obstruction 2.5, like that it goes. And if it is more than 3.5, the predicted risk is 70%. And these are all the red flag symptoms: chest pain, dyspnea, orthopnea, cough, edema, otherwise anasarca, tachycardia, non-vagal syncopal attacks, severe headache, visual disturbances, hypotension and hypertension. These are all the red flag symptoms. And what are all the red flag signs? Persistent tachycardia, SpO2 of less than 94, presence of cyanosis and clubbing, elevated JVP, crepitations, new murmur, loud pulmonary component of the second sound, peripheral edema, hepatomegaly, right hypochondrial tenderness, hypotension indicating cardiogenic compromise, arrhythmia detected on the pulse examination. Sometimes in the JVP you can see the Cannon waves. So this is the evaluation strategy: simple history taking, clinical examination, ECG, echo, biomarkers, and very rarely we will go for the imaging, alternate modalities like cardiac CT and MRI. And the isotope studies are extremely rarely indicated. And these are all the management principle. I am not going into the details. Like any other non-pregnant women, pregnant women should be treated with all the drugs except for those drugs which are contraindicated during pregnancy. We have to plan the delivery. Always it should be an institutional delivery by the heart team approach. So the postpartum care is also very important. Excessive IV fluids, excessive transfusions should be avoided unless properly indicated, and arrhythmia should be managed. Early mobilization will avoid pulmonary embolism. Educating regarding the warning symptoms will be very much essential. We have to follow them. And this is regarding the contraception, postpartum monitoring, future CV risk, etc. They have to come for follow-up at least 15 days, 1 month, 3 months and 6 months. And this is especially for those who suffered GDM and hypertensive related problems. So this is regarding the choice of medications, what is the drug category in which the drugs are indicated, etc. And this is regarding the peripartum cardiomyopathy. What is the class 1 indication? Counseling for women with peripartum cardiomyopathy about the risk of recurrence. We have to tell them clearly. So like that it goes on. I am not going into the detail. This is one case, 21 years. On her postnatal day, 36 came with a peripartum cardiomyopathy, and she was medically managed. Since she developed this cardiomyopathy, for up to 45 days the OG team will see. After that they will refer to the cardiologist. So the auto EF is saying if 44 as a EF, and she is planning for the next pregnancy. If planning, we have to go for 6 months. After 6 months we have to reassess the EF. If it is more than 45, we can allow them that too after the good interval of at least 2 to 3 years. So this patient had a diastolic dysfunction, etc. So this is how it goes. And this is another patient with 27 years old female with 37 weeks of pregnancy, history of scoliosis and plate in the spine. And she came for complaints of mild dyspnea and showing reduced EF of 38%, possibly a cardiomyopathy. But to our surprise, she had a aortic dissection flap in the ascending aorta, also in the 3D. You are able to see the valve, and above which there is a flap seen. So aortic dissection, what we are going to see. So this patient underwent LSCS emergency and now kept in the MICU ward to be taken over by the CVTS team. So they are planning some dental procedure like that. And this is a risk monitoring and management during pregnancy and delivery in a woman with the congenital heart diseases. I am not going to the details. Especially when they have AVST, we have to be very careful. Repaired TOF, AST, even VSTs, we have to put them on beta blocker to avoid supraventricular tachycardias and SCAR VTs. Next, this case is a Epstein's anomaly. And we actually measured the ghost score. It was around 0.57. So we subjected her for medical management. Only the beta blocker we have given. So like that it goes on. And this is another patient with dyspnea, about which sir was telling, the bicuspid aortic valve. She underwent a successful balloon aortic valvotomy and very good valve area. The same manner. She came for the second time with pregnancy, and we advised MTP and TAT for her, and she is still doing well now. And the recommendation as far as this is concerned, pregnancy termination is concerned, this is regarding the ophthalm, this one. And this is an interesting case with the reverse wiring PTMC we have done in our institution. So with this, I would conclude with my take-home message that we have to risk stratify by either Zagara score or Corprex score or modified WHO score, and we have to identify the red flag symbols and signs. And we should aim for a good survival in the maternal as well as fetal outcome. Thank you very much for patient listening, and thank you for the wonderful opportunity.
Excellent talk, Dr. Selvarani. In fact, it is a class for the postgraduates, you can say. Please take the chair as there's no time. Later on, we'll take up. So next we call upon...
Dr. Chabbi's come. Chabbi Satpathy. If she's not there, we will invite Dr. Geeta to give PPCM talk. I heard that Dr. Asha Murthy is not here.
No, she had a sad demise in the family, so Geeta is going to present. Yeah. Geeta is a senior cardiologist from Jayadeva, Sri Jayadevan Institute of Cardiology, Bengaluru. Please,
Thank you,
Geeta.
Madam. Thank you. Good
Yep.
morning, everybody. And in the outset, I have to thank Dr. Sarita Madam, Josna Madam, and Vijayalakshmi Madam, and everybody here. I mean, it's a great morning to meet all of you. And here I am today to talk about peripartum cardiomyopathy. And my thanks to Dr. Asha Murthy for having given me and created the opportunity to talk about this topic. And coming to this today's topic, it's peripartum cardiomyopathy. What's new about it? According to the European Society of Cardiology Working Group 2025, peripartum cardiomyopathy is a potentially life-threatening condition defined as heart failure with reduced left ventricular ejection fraction below 45% without any causes of heart failure, occurs mainly during the peripartum period or in the months following delivery, termination, or miscarriage. Peripartum cardiomyopathy is essentially a diagnosis of exclusion and requires urgent management. So, currently it's classified as non-familial, non-genetic form of dilated cardiomyopathy. The incidence is 1 in 3,000 live births. The risk factors for developing Peripartum cardiomyopathy is woman older than 30 years of age, history of pregnancy associated with hypertension, women with multifetal pregnancies. Next slide. No.
This way.
Yeah.
Yeah. Keep.
According to the new guidelines 2025-2026, the guidelines focuses on early diagnosis, aggressive heart failure management, and managing the prolactin fragment with the BORD approach. BORD approach is bromocriptine, oral heart failure drugs, anticoagulation, vasodilators, diuretics, and diet. Cardiovascular disease emphasizes a multidisciplinary pregnancy heart approach. The key guidelines include 6-month minimum guideline-directed medical therapy, including AC inhibitors, ARBs, ARNI, and SGLT2 inhibitors, bromocriptine therapy during the postpartum period. Temporary wearable cardioverter defibrillators early, and it's mandatory. Close surveillance of the cardiac function with echocardiography until LV ejection fraction recovers. The risk factors are probable risk factors. It includes twin pregnancy, multiparity, multigravity, extreme of reproductive age, prolonged tocolysis. Then the proposed risk factors: smoking, hypertension, malnutrition, cocaine abuse, African ancestry, and low socioeconomic status. And the emerging risk factors are genetic preeclampsia and obesity. Madam, I want some water. Water, please. Sorry for the interruption. The risk factors, the older the maternal age, more than 30 years, in the majority of the times it's African descent, preeclampsia, hypertension, and obesity, multiple pregnancies, smoking, and diabetes. The incidence is 1 in 300, as I told you earlier, and the pathophysiology is often linked to increased oxidative stress, leading to cleavage of prolactin into 16 kDa apoptotic antiogenic fragment, which results in the cardiomyocytes ischemia and leading into the endothelial dysfunction. The etiology is viral myocarditis, abnormal immune response to pregnancy, abnormal response to increased hemodynamic burden of pregnancy, hormonal abnormalities, malnutrition, inflammation, and apoptosis. This is a picture showing the pathogenesis of the postperipartum cardiomyopathy, where there is actually a disruption between the cathepsin D and prolactin disruption, leading into the endothelial dysfunction apoptosis with cardiomyocyte ischemia and metabolic insufficiency, leading to apoptosis. The differential diagnosis of peripartum cardiomyopathy are the pre-existing cardiomyopathy, including valvular disease or congenital heart disease, pregnancy-associated myocardial infarction, pulmonary embolism, and amniotic liquid embolism, then myocarditis. Coming to investigations, BNP, there'll be elevated BNP and NT-proBNP levels. In the chest X-ray, you will see a increased cardiac silhouette with evidence of pulmonary venous congestion and interstitial edema. Then echocardiography, where you'll see there's a reduction in the LV systolic function with less than 45%, and it's frequently but not always dilated. Then there's a possible left atrial enlargement, left ventricle or left atrial thrombus, dilated right ventricle. Normally right ventricle is not involved, but it's better it doesn't get involved. But if there is right ventricle hyperkinesia, there will be mitral and tricuspid regurgitation, and rarely sometimes there will be pericardial effusion. The risk stratification to precision care. Now in 2025, the guidelines for the management of cardiovascular disease and pregnancies is, there's actually a pregnancy heart team where it's a combined effort of the anesthetist, cardiologist, obstetrician, nursing, and other relevant specialists. They see the patients throughout their preconception time, pregnancy time, delivery plans are made for them, and during the postpartum. In the long term, it's to identify the adverse pregnancy outcomes because of hypertension, gestational diabetes, preterm births, small for gestational age, and cardiovascular risk factors should be screened. The board therapies for peripartum cardiomyopathy is, the mainstay is bromocriptine, 2.5 milligrams for 7 days, or you can increase it for a longer treatment in severe cases. Oral heart failure drugs, beta blockers, AC inhibitors after stabilization, anticoagulants, heparin immediately in at least as a prophylactic dose, relaxants, vasodilatation if the systolic BP is more than 110, diuretics, and now of late pentoxifylline is also used to reduce the inflammation. The anticoagulants itself is, pregnancy itself is hypercoagulable state with decreased body's natural anticoagulant. So consider anticoagulant following patients where the EF is less than 35%, when there's paroxysmal and persistent AF, documented mural thrombus, evidence of systemic embolism. Warfarin and heparin both are safe during the breastfeeding. Then the other assisted devices are IABP, ECMO, left ventricular assist device, biventricular assist device, ICD, and CRT. This is the recommended ESC 2025 guidelines, which is recommended for the peripartum cardiomyopathy. The management part is early delivery is not required if the maternal and fetal conditions are stable, and epidural analgesia is preferred during labor. Advanced heart failure, prompt delivery for maternal cardiovascular indication is suggested. Planned cesarean delivery is preferred for women with advanced heart failure requiring inotropic therapy or mechanical circulatory support. Breastfeeding to be avoided because of the potential effects of prolactin subfragments. Benefits of breastfeeding in stable patients if it's compatible with other medications. The peculiarities in the management of acute heart failure caused by peripartum cardiomyopathy is multidisciplinary approach with focus on health of mother and fetus, avoidance of heart failures, drugs with fetal toxicity during pregnancy, that's the AC inhibitors, ARBs, then mineralocorticoid receptor antagonists, and breastfeeding. Thereafter, standard heart failure therapy can be considered. Then consideration of bromocriptine, 2.5 mg twice daily for 2 weeks, followed by 2.5 mg per day for 6 weeks, in addition to standard heart failure therapy. Anticoagulation with heparin to avoid cardioembolic complications in patients with left ventricular failure less than 35% are treated with bromocriptine. In case of cardiogenic shock, you can consider levosimendan 0.1 micrograms per kg minute for 24 hours. Prevention of sudden cardiac death, early consideration of wearable cardioverter defibrillator devices in patients less than 35% is advised. Bromocriptine in 63 patients with less than 35% were randomly assigned to short-term therapy with it, which really increased the left ventricular ejection fraction. So the REBIRTH trial, where it's a randomized evolution of bromocriptine in myocardial recovery therapy, is it improves heart recovery and survival in women with peripartum cardiomyopathy. This is from the European Heart Journal. The maternal outcome studies reported are LV function at 6 months is 45% to 78% of the patients with a mean of 54%. The mortality rate between 0 and 19%. Rates of cardiac transplantation is 6% to 11%. The predictors of maternal mortality, LVF, reduced LVF, that's 30%, high maternal age, black, race, multiparity. Subsequent pregnancy and risk of relapses, LV ejection fraction, if it's, madam, once if the ejection fraction is less than 25%, you should tell them not to conceive further in pregnancy. Okay. When prognosis of the patient, finally 50% of the patient complete recovery is seen, 25% of the patients persisting some symptoms are seen, 25% of the patients they develop complications, heart failure, arrhythmia, and thromboembolic episodes. Mortality is 3% to 9.6%. This is one of my friend who is a doctor and worked in Jaidava. Prabha madam, then Vijayalakshmi madam, all of them helped her out, come out from this peripartum cardiomyopathy. Her name is Dr. Savita, and she's had a post cardiac transplant, and she is running through 9 years now. Give her a big applause and pray, Lord, that all these kind of peripartum cardiomyopathy patients have a good life in future to come, to see their children grow and become good civilians. I pray God bless all. Thank you. Thank you.
Thank you so much, Geeta. That was an excellent
It was because of
presentation.
you and it was a very
In fact,
short time,
in fact, one of my patients with peripartum cardiomyopathy, she came with the convulsions because she had a thrombus in the LV, thrombus in LA, and they were throwing the thing. And that's why anticoagulation is very, very important. Very well done. Excellent.
Thanks.
Any questions from the audience or expert panelist?
That is, during pregnancy, you're not supposed to use that thing.
Postpartum.
After pregnancy, postpartum, you can use it, madam. Yeah, it is advisable actually. In heart failure patients, that's what we use.
Yeah, then what about, is there any role at all with the drug agents when it comes to anticoagulation?
No, madam. No, madam.
No studies.
No. Thank you, madam.
Yeah, please, please.
So hello to everyone. I'm an obstetrician and we are getting a lot of patients who are having high risk factor like age of conception is increasing, IVF conception, so twins are more, obesity, hypertension. So what advice would you like to give to prevent PPCM? Is there any medication or further advice?
Ma'am, peripartum cardiomyopathy is a diagnosis once patient has suffered. There is no preventive measures, but of course you can prevent over distension of the abdomen, multiple pregnancies you can prevent. So these sort of things can be done. But Madam said in one slide, the first slide, it's a non-genetic. It is not like that. Some of them show there is a genetic mutation, deletion, etc. So if she is really planning for the second pregnancy, we can give a counseling for genetic studies. And then other parameters, like now the global longitudinal strain in the echo, it's a very accurate method. It's a non-invasive method. If the EF is more than 45, we can allow them to go for further. And we have to take care of these things, pregnancy-induced hypertension, diabetes, all the preventable risk factors, the risk factors enumerated, no? So we can avoid them. Role of diuretics we can use, but digoxin is a little bit, you have to be very cautious. And all the other drugs like ACE, ARB, and mineralocorticoid inhibitors, SGLT, they are all contraindicated during pregnancy because there are no studies and there is a teratogenicity.
Okay. Anything from the audience? Okay. If no more questions, we would like to conclude this excellent session. Congratulations to all the wonderful speakers. Thank you.
Dr. Rajeshwari, I would just like
Chairpersons
to...
and expert panelists.
Yeah.
Indeed.
I would like to just wrap this up. See, essentially, what we need to do is we need to avoid emergencies. And for that, our assessment, apart from the risk scoring, I think what we need to do is we need to have a
I'd like to request our chairpersons, panelists, and moderators to kindly proceed for the felicitation at the presentation wall. Thank you so much, everyone, for your gracious presence. I'd like to request you all to kindly proceed for the felicitation at the presentation wall. Ladies and gentlemen, कहते हैं मुश्किलों का ही मज़ा है ज़िंदगी में, हो अगर हासिल सुकून तो ज़िंदगी क्या. It says that growth begins the moment we step beyond our comfort zone. And trust me, it took a lot of courage to become what you all are today. So everyone, let's begin our next session with the spirit, with the enthusiasm that will take this conference at another level. Let's begin our congenital session, everyone. Nipping in bud or stitching in adulthood. Let's invite our chairpersons. I'd like to have your support. I'd like to request you to join me in a big hand to invite our chairpersons, Dr. Meenakshi Cardiology ma'am, Dr. Vidyut Jain, Dr. Manisha Chakrabarti, Dr. Nishit Bhargav. In our expert panel, everyone, we have Dr. Smruti Patel, Dr. Annie Princey, Dr. Priyanka Poddar, and Dr. Aruna Hinal. As a moderator for the sessions, I'd like to invite Dr. Soumya Kasturi ma'am. And ladies and gentlemen, can we have a round of applause for our expert panelists, our chairpersons, and our moderator? I'd like to request our chairpersons, moderators, and panelists to please join us at the dais. Let's invite our first speaker for the session, Dr. Anita Saxena ma'am. She'll be talking about Eisenmenger syndrome. Is it end of the road? Please welcome Dr. Anita Saxena ma'am.
Chairpersons, respected chairpersons, I would like to begin by thanking the organizers of World Congress for inviting me and for keeping this topic, which is something that I think all of us do see in our practice from time to time. So the question is it end of the road for Eisenmenger syndrome? Once you make the diagnosis, is it end of the road? So let me just begin by showing two very, very important gentlemen's pictures. One is, of course, Eisenmenger himself, who described this entity in a 32-year-old lady, 32-year-old man, but in a postmortem. On the other hand, we had later, much later, that is in 1958, we had Dr. Paul Wood. I think everybody is well familiar with Paul Wood's book that we've all been reading. And he labeled this particular disease as Eisenmenger syndrome since it was described by Victor Eisenmenger for the first time. So what is Eisenmenger syndrome? It is pulmonary hypertension at or near systemic level with reversed or bidirectional shunt between the pulmonary artery, pulmonary and systemic circulation at any level with a PVR of more than 800 dynes per square centimeter, which becomes 10 Wood units. So basically we are saying that there is severe pulmonary artery hypertension with resulting in reversal of shunt or near reversal of shunt. So why does it happen? Eisenmenger syndrome is not congenital. What is congenital is a defect, an ASD or a VSD or a PDA, but over a period of time, it produces a lot of increase in the pulmonary vasculature, remodeling of pulmonary vasculature, endothelial proliferation, dysfunction, and that leads on to irreversible changes in the pulmonary vasculature with an increase in pulmonary vascular resistance, and that is when we call it Eisenmenger syndrome because the shunt reverses. So the initial part is hyperkinetic PAH. There is pulmonary artery hypertension, but that is hyperkinetic and the pulmonary vascular resistance is normal. However, later pulmonary vascular resistance also goes up and we like to call it obstructive PAH or Eisenmenger syndrome. So the process starts rather early, although we see these patients usually in their second and third decades, but the process of irreversibility starts almost at 2 years, 3 years, or even 4 years. And this is one series of 206 patients of Eisenmenger syndrome from recently published from Sri Chitra. And you can see that ASD, VSD, PDAs are the dominant lesions which cause Eisenmenger syndrome when you see them during adulthood. Now, coming to the survival, I think we all know that Eisenmenger syndromes do not have a normal survival, but then they don't do too badly, as you see the curve when compared to the normal controls. So life expectancy is about 20 years less than that of normal, and what is important to understand is that unwarranted surgical closure will hasten death. So this is what I'm trying to say, that if you have continue to have Eisenmenger, that means you don't close the shunt, then the survival is not bad. But if you decide to close the shunt in patients who was inoperable or borderline operable, then you are actually making them almost like primary pulmonary hypertension and they die much earlier. So therefore, it is better not to intervene in these patients. Policy of non-intervention is what we need to do for patients of Eisenmenger syndrome. Now, what are the factors that determine the survival of? I've shown you that survival is not bad, but then there are variations within the various patients, and the reasons could be the level of shunt. Generally, ASDs, although develop Eisenmenger much later and not in all, but the overall survival in ASDs is, or pre-tricuspid shunts is worse than post-tricuspid shunt. That means VSDs and PDAs behave little better. Then there are many other factors that that will also sort of interfere or let's say determine the outcome. For example, saturation, 6-minute walk distance, age of the patient, what is, as I said, pre or post tricuspid shunt, and pericardial effusion. So if you let's say have a 40-year-old person with an Eisenmenger syndrome, which is a VSD, has a reasonably good 6-minute walk distance, reasonably good saturation, you can see that his 5-year survival or 5-year mortality is less than 10%. So this is really an optimal group that you will have. So within the same profile of patients, you can differentiate. And if there are any of these factors, then we will say it is a less favorable outcome. Older age, pre-tricuspid shunt, low saturation, loss of sinus rhythm, and so on. Now, what are the key principles of management? Timely initiation of pH-targeted therapy in symptomatic patients, not in asymptomatic, but in symptomatic patients, preventing complications, regular assessments, supportive measures, and these are very well summarized in this particular review article that is published in 2022, where they were given a kind of a holistic approach as to how we should follow these patients. And it is very important that they come for follow-up at regular intervals. And as I said earlier, doing nothing may be a positive action. 20% of deaths are related to avoidable errors, and I would specifically like to highlight that there is no place for phlebotomy in these patients, even if their hemoglobin is 18 or 19 or 20, unless you really prove that they are not iron deficient and their symptoms are because of hyperviscosity, which is very rare. Similarly, if they need any non-cardiac surgery or anything, this needs to be done in a very expert center, because anesthesia drug can be very, very dangerous for them by reducing the balance between PVR and SVR. And of course, we are very aware that pregnancy is to be avoided. And here I just would like to show you one slide, since we are in a WinCar conference, that this is the big ROPAC registry, where I think we will, our MPAC registry will also or NPAC registry will also be reaching very soon. This is 3,295 pregnant women with congenital heart. And as you can see, ASD is the commonest lesion, but there is still a small percentage of patients of pulmonary artery hypertension, which includes Eisenmenger. So the percentage is quite small, but when you look at morbidity and mortality, this is where it becomes so much more. So there is a mortality of about 10-15% and a morbidity in heart failure in 58% of women. So this is really a contraindication for pregnancy, not just for high maternal morbidity, but also high fetal loss. What are the advanced targeted therapies? I think we are very well aware of ERAs and PD5. All these are the drugs that we use. Often we start with bosentan. One can also start with one of the PD5 inhibitors like sildenafil. But one starts with monotherapy. Of course, if there is a little more optimization required, you can actually go to combination therapy. Only in high-risk cases we go for triple therapy. And there is not much data on these drugs, Selexipag, which is a relatively new drug, prostanoid analogs, and also there is not much data of upfront combination, something that we have started doing in all IPAH or idiopathic PAH patients. But most of the centers will be using bosentan, because we know that there is a good data on BREATHE-5 trial where they have used bosentan in symptomatic Eisenmenger patients with good results. And does therapy help? Yes, this is a very recent study from Japan where you can see that patients who received therapy did much better than those who did not. And same is the data in patients who were seen at Sri Chitra, and you can see that their ages are little younger compared to the patients who have been published from Japan. And even at 30 years, you have a significant difference in survival. This is follow-up. This is not age of the patient. This is follow-up years. Much better if they are on therapy than those who are not on therapy. Other important considerations, I think I did mention about arrhythmias. Diuretics needs to be used very carefully because we know it can decrease SVR, can increase RV, right to left shunting. So one has to have a very fine balance between SVR and PVR, and that is what is very important. All cyanotic patients require antibiotic prophylaxis. They should all be vaccinated because any infection can really push them over and they may deteriorate. And of course, avoid phlebotomy. And this is very nicely summarized in the recent ACC guidelines that have been published in late 2025 for adult congenital heart disease, and one can really go through. So to summarize, I would say, is it end of the road? The answer is no. I've shown you good data to say that they do survive for a good number of years, but they need to be managed properly. An approach of masterly inactivity is recommended. This is the word that Dr. Jane Somerville uses for many, many years now. One has to prevent complications. One has to avoid medical errors. Pregnancy is contraindicated. Phlebotomy is to be avoided. Pulmonary artery hypertension targeting therapies should be started early in the course of the disease, especially in those who are symptomatic, because these drugs are known to improve survival. One should start with monotherapy, and if required, can go to dual therapy. And with meticulous follow-up and a healthy lifestyle, most patients can lead a fulfilling life. Thank you very much for your attention.
Thank you very much for highlighting this important topic. I think we do come across the patient, and the patient's relative always expect we should do something for them. And you told very clearly, masterly inactivity may help better, and I think that is what the theme. And we have got patient around 40 years follow-up, Eisenmenger. Angiogram done in 84, they are surviving in 2026 also. Madam, apart from the Selexipag, since it's available, we know there are not trials available, boosting it, but in idiopathic pulmonary artery hypertension, it's working well.
Yes, yes.
There's another molecule, sotatercept injectable.
Yes, sir.
Although it's not available.
It's available now.
Available?
Yes,
Okay,
it has become available this month only.
Once a week or something.
Yeah, it's become
So
available.
it may be really some answer.
I think sotatercept, I would just like to say that there has been abstracts which I've seen them being presented in some of the recent meetings where they've done it in 2 cases or 3 cases like that and showed good result. But to be fair, as of now, it is not recommended for Eisenmenger syndrome. Yeah.
Excellent presentation, ma'am. Just one thing or maybe 2 things. First is in our daily practice, the Eisenmenger syndromes we see is mostly because of VSD. I think the data suggests it's ASD. But for us to see ASD with the Eisenmenger, it's a rare thing now. Secondly, I just wanted to clarify one thing. Like most of these patients who are Eisenmengerized, they do have a life expectancy maybe 20, 30 years lesser than normal. Yes. But I think whatever life they have is quite restricted, as in they have a lot of hospital admissions, they have recurrent arrhythmias, they have recurrent symptoms for which they run to emergency every now and then. What's your take on that, ma'am?
I wouldn't agree to that. Yes, they do require very close care, but if like I have a patient, I think I had, that patient is no more, till 64, he would come regularly to me every 6 months. He would come regularly to me if there's any need for, let's say, dental extraction or something. So I think patients as well as doctors have to be very, very thorough in the follow-up. Only if you sort of don't do anything and only come at the last moment, yes, they are sitting on a fence, they will fall. There's no doubt about it. But this is what we need to emphasize to our patient, that they can lead a good life provided they are on a regular follow-up and they contact us if there is any issue. For example, non-cardiac surgery, patients just die on the table because of anesthesia complications. So, and with these drugs, things have become even better. what I'm telling you is more of a natural history. I think my patient was perhaps not on any drug because those drugs were not even available. But with the drugs, I think you saw the Japanese data, 30-year survival is something like 50-55%.
I think what ma'am said is right. I would agree more with that, because if earlier the child comes, yes, the restriction of activity will be more for the parents, when they compare them to the peer children. But if you guide them well and if they are followed up well, minimal intervention in fact helps them better. You diagnose them Eisenmenger, start on multiple drugs, restrict them too much, and then they may, shorten their lifespan. And you have to keep insisting that every procedure, even if it is a small for the child, the doctor needs to be informed about the disease. Even if the child has saturation of 90 or 88, the pediatrician may not know it, the pediatric surgeon may not understand it. But you still have to insist that anesthetist should be informed about it, so the child is taken care. So the complications, if you avoid them, I think the life expectancy goes up beyond 40. Majority.
I think pregnancy is another area where we lose
mortality. We lose
patients.
maximum during pregnancy. Even if you said morbidity, I think it is more than 50% mortality. And in the during the pregnancy only they are diagnosed. We are not able to manage, and majority we lose.
Yeah.
Even after counseling also they are taking chance and
Yes, I agree. I think pregnancy is something that's kind of taken for granted in our country. And even if you tell them not to, yes, there are compulsions. I'm not. Yeah. So I think
is married, and then the parents will just ignore your advice.
I think there is data from Kochi and other places where very meticulous management during pregnancy has helped them. But no, I would still not advise pregnancy. But if they are very keen to have a baby, if there are issues, perhaps we can help them and reduce the mortality. The study from China, a huge study of 700 odd cases, 5% mortality. It's high, but it's not that high as we are used to seeing. Yeah.
But at this day and age, for the postgraduates, we should not have Eisenmengers later. Whatever Eisenmengers we have seen are from the last 20 to 30 years. Now there is no weight restriction for any VSD which is diagnosed in the newborn period or in the early childhood to get operated. You don't have to wait till 8 kilos. You don't have to wait till 10 kilos. If we strive to that, the Eisenmengers numbers will definitely come down. We should be doing that with so many of us on board.
Yes, they have come down, but even in Western countries, it's 2 to 3% per 1,000. I mean, 2 to 3% of all CHDs are still Eisenmenger. So I think we should try, and our numbers are coming down, but I think we'll still not ever get rid of it.
Ma'am, what is your take on home oxygen therapy? Because post-COVID oxygen concentrators are more available. So what is your take on that?
So I think in Eisenmenger, they don't help much. In primary PH, they do. Oxygen helps. But in Eisenmenger, it doesn't help much. But there are patients who feel more comfortable after taking oxygen. So I would tell them, okay, at night, take 7-8 hours of oxygen if you wish to. But those are the patients who are reasonably blue. And most of our Eisenmengers are in 80s. Most of them are in 80s. They are hardly ever lower than 80. But in primary pH, even with higher saturation, oxygen definitely helps because it reduces PBR. In Eisenmenger, the trouble is if you reduce PBR, you increase shunt. So it's a very difficult situation.
You want to highlight on use of sildenafil or bosantan in hyperreactive pH, because a lot of cardiologists tend to use it.
I think we are fooling ourselves. We should not do it. Once patient is inoperable, patient is inoperable. Only thing is you should have taken every measure to see that patient is inoperable, not just cath data, clinical data, X-ray, ECG, every echo. But once you've decided the patient is not operable, I wouldn't waste time starting vasodilators. I have done in 6 or 7 patients earlier when I was very enthusiastic about it. None of them really became operable. In ASD, maybe there is a case because ASD patients with PAH are not really Eisenmenger in that sense. They are more like idiopathic PH with ASD. So in ASD, there may be a case of doing it, but not in VSD and PD.
Absolutely second that.
Quality of life of these patients, if we use, because I found that in non-operable patients, using this vasodilator, sometimes the patients feel better.
I think there is data to say that they feel better, their long-term survival is better, their saturation gets better. Yes. So there is definitely a role, but I wouldn't start it in somebody who diagnosed as Eisenmenger, asymptomatic nearly, good 6-minute walk distance. like people have started doing in IPH. I would wait because remember these patients are going to need it for the rest of their life. So I would start one, keep in reserve another one, later give even 3 drugs if required, but go rather slowly. Yeah. Okay.
Okay. Thank you, madam. So, now I invite Dr. Vijaya Lakshmi, who shall be talking on one very critical situation, coag when to repair or to operate. The coag is always a problem if they come in early infancy or if they come after age of 30 years. Both the situations are very difficult. So I think we'll just get all the inputs from Dr. Lakshmi.
Thank you, sir. Respected chairpersons and dear delegates, it's a pleasure to present about the coarctation, repair or dilatation when I grow up. In fact, the coarctation of aorta is a congenital abnormality producing obstruction at the descending aorta. You all know it may be shelf-like structure or membrane or curtain-like, or it may be an eccentric with the hypoplastic arch. What is important is over the past decades, intravascular stenting of coarctation of aorta is a primary therapeutic option and has become an attractive, effective and alternative to the surgical correction in most of the adults and the adolescents. When you look at the advantages and disadvantages of the repair, the open heart surgery is better, but ideal treatment for the severe complex coarctation of aorta. But when you come to the disadvantages, there is collaterals can be problem, long-term cardiovascular damage may be there, such as coronary artery disease and also damage to the left recurrent laryngeal nerve, bronchial compression and the spinal cord ischemia because the anterospinal artery comes there and during the repair it may get damaged. And what is important is the complications are enormous. Acute or chronic heart failure, paradoxical hypertension and chylothorax can occur. Long-term patients with the less than 3 years, restenosis is as high as 41%. And persistent hypertension, aortic aneurysm formation, restenosis, it is almost 51, and intracranial hemorrhage and uncontrolled hypertension in the upper limb, and the survival is only 73% at the end of 30 years. So this is a patient of, at the age of 22, he was a gardener. I detected him to have BP of 220/120 in the upper limb, and then he was the first ever aortoplasty to be done in Karnataka. And now his son is a doctor and he's preparing for the post-graduation. And that time we didn't have the stents. He has a fusiform aneurysm, but still he's all right. So now that we have the CT angio, volume rendered reconstruction images are very useful for both repair as well as the intervention. And now we have the various types of stents, the covered stents, the growth stents, and various types of stents. And the balloon, we have balloon in balloon. So all these things can have reduced the complications and the intervention that we were getting in the past. In fact, I remember Matthew said that the very first case of aortoplasty he did was ruptured and he lost the patient. And that's how we know that those days were there. But today, no more. So here you can see that this is the 20-year-old person diagnosed as rheumatic fever and on atrial fibrillation with pulmonary edema, taken on the table for the balloon dilatation. The moment I felt the pulse, I said this is coarctation, and my professor wouldn't believe it because the echocardiographer had told the mitral stenosis. In the same sitting, I did the balloon dilatation, simple balloon dilatation, and also the PTMC in that patient. So this is this, whenever the simple coarctation is there, it is not difficult. Straight away you can go and stent it and be done with that. But when it is difficult, the presentation is difficult. Here you can see that the patient along with the coarctation has got the ruptured sinus of Valsalva also. So always the distal lesion has to be dilated, that is the coarctation, and then come to the proximal and close it with the device. So here, so coarctation is not able to cross retrograde because of the malalignment. Whenever the malalignment is there, you can go from the upper limb and along with the flow with the thermo guide where you can cross it, snare it, and then you can go retrograde and then put the stent. We get the excellent result as we got in this patient. So here the pre-dilatation is required in certain cases where there is a tight stenosis. At that time, you open with the small balloon and then stent it. So here, if the re-stenosis is there, it is difficult for the redo surgery and the post-surgical, and that time we can go and dilate and then put the stenting, and then this is how you get the excellent result after putting the stent, even if it is a re-stenosis after the surgery. So here, whenever there is a bigger balloon is required, then at that time we can re-dilate the stent which is not adequately open. But sometimes they can have the PDA. With the covered stent, you can treat both the coarctation as well as the PDA. But suppose the patient is not able to afford the cost of the covered stent, and then what we can do is do the angiogram, dilate the coarctation, put the stent, and then redilate. This is how we can get an excellent result with the PDA, device closure, and the dilatation. So sometimes the pinching of the left subclavian artery is there whenever we put the stent, and for that can be predicted in time, and we can go through the stent and dilate that with the balloon and see that the flow across the subclavian is all right. So today's CT angio is very helpful for making the complex cases and also to design what sort of treatment we have to give. Sometimes what happens is when the coarctation is there, and when we, in spite of measurement and keeping the stent properly, sometimes it can migrate and jump a bit. And that time we don't have to lose your heart. Just go ahead and hold it with the bioptome, pull it down, and then once it is slightly brought down, even if it is partially dilated, and then you dilate it further to get an excellent result. And this is the final result. You can see that absolutely we don't realize that the migration has occurred and the alignment is perfect. Now we have 3D, 4D image fusion for live guidance and the stent implantation in aortic coarctation, magnetic resonance imaging and computed tomography image, or we can have the use for the interventional technique, especially in the complicated cases. So what are the complications in the intervention? The rupture of aorta, extremely rare because we don't over-dilate. And then stent displacement, and that also can be attended. Then stent fractures can occur, the stent aneurysm can occur, and then balloon rupture also can occur, and all these things care can be taken so that we don't reuse the balloon when we are doing such a case like this. The old balloons are not used. So pre-catheterization with the 3D, MR or CT assessment is very important, and the baseline hemodynamics have to be seen, and the aneurysm has to be seen. So here there is an aneurysm already operated, and now the aneurysm has occurred. You just put a covered stent and be done with that. You get an excellent result without a problem. But only thing that you have to see where the anterospinal artery is coming, because if you block the anterospinal artery, the paraplegia can occur. So the types of stentings are there, and the stent fracture can occur. We can re-stent. So to conclude, the diagnosis of coarctation is not missed if proper attention is paid. Congestive failure can be prevented if we dilate in infancy and then attend to it later on. So balloon angioplasty should be considered in the native coarctation. And what is more important is look at the difference. The pictures are there. And the person who has undergone, even if they wear a bikini or whatever it is, nobody can make out that there was a coarctation. The scar is small, the blood transfusion is not there, earliest mobilization, shortest hospital stay, quickest recovery. So the surgery is logic, but intervention is magic. And that's how the transcatheter treatment of coarctation of aorta are safe, effective, and attractive alternative to surgery. Just because it is attractive, don't get distracted. Otherwise, you land in crash in the cath lab. So better to have a proper imaging. And thank you very much for your kind and the patient hearing. And thank you.
Well, very well done. And I think we have to learn that coarctation should be attempted as early as possible in infancy, so patient doesn't get into complications. We had some problem in the adult. Definitely delayed operation or delayed intervention leads persistent hypertension. That means the BP doesn't resolve. So that is our
So the persistent hypertension can occur with both, whether you do the dilatation or the redo surgery. But the redo surgery, the problems are, enormous, like, bleeding through the collaterals. And then, the problem is with the anterospinal artery. When they put the graft, the anterospinal artery may be damaged, the chylothorax, all those things are there. And all that can be eliminated with the interventions and the endovascular stenting.
We did one adult at the age of 40. Ultimately, she unfortunately developed dissection. But the dissection is now followed with 26 years. She's doing all right.
Yes, sir.
Yeah.
So the hypertension, we have to treat it because, in adult coarc, that's the problem.
Ma'am, mostly, what we follow, I'm a cardiac surgeon. So what we follow is we try and do the coax as early as possible, probably neonatal or infant period. So during that time, the tissue is very nice. You can easily mobilize and do an end-to-end anastomosis. I think that patch plasty and all is absolute now. Nobody does it anymore. As far as adult patients are concerned, even we would love that if somebody can stent it, because it becomes quite challenging with the collaterals and we have to go to midline. Otherwise, it's just a thoracotomy, a small incision.
Yes, sir.
But doing it to midline in an adult is very painful. It would be very nice if somebody can
I know. I do agree with you. This coming from a surgeon, we have to give a big hand for the person with the lion's heart and the lady's fingers in.
I just one point. The persistent hypertension, sir, remains even if we earlier do it. In infants also,
Same.
the persistent hypertension remains. It's part of having a coarctation. So the follow-up needed is very much important.
Yeah.
So majority of the infants, I'm a pediatric cardiologist, so I deal with children. So the parents are happy the moment you do coarctoplasty, whether surgical or non-surgical. They go home and they don't tend to follow up. So we have to keep insistent that this hypertension may be affecting the child when he grows up or even during the childhood. And with 1 to 5% risk of Berry's aneurysm being present there, which we may not be able to pick up on MRI earlier. So we have to follow them up. So the risk of CNS bleed increases. Berry's aneurysm plus, undiagnosed hypertension. So the follow-up remains the key for, I think, those. Even if
I'm also a pediatric cardiologist. The youngest that I have done is 4-day-old.
You don't have to say it, ma'am, what you
with
are.
LV dysfunction. And in fact, many people by looking at the LV dysfunction, they think it is a dilated cardiomyopathy and put inotrope, because they don't feel the pulse in the lower limb. And that is how, and they don't record the blood pressure.
Overdiagnosed during fetal echo and is missed during infancy.
Yes.
It's
So, but what
overdiagnosed.
I would like to say is, with the refinement, with the options, we have better to, we can do handle the patient better. That's what I wanted. Thank you.
Now I have pleasure to invite Dr. Sanyukta Bose, who shall be talking about parastatrology repair and what is their follow-up now. And the problems of the once they become elderly people or middle-aged, they do come across some complications. Yes, please.
Very good morning. Very obliged to be here with all these eminent figures who we have looked up to. We running a very young cardiac unit here in Indore. And so I would like to thank WCC, Dr. Sarita Rao and Roshan Rao for giving us this lovely opportunity. And they are a rock for us. They are our backup in Apollo Hospital Indore. So let's get on with the topic. as we know, cyanotic heart disease, most common being tetralogy of Fallot's. We have already operated more than 500 patients with tetralogy of Fallot's. So these kids are growing up and they are already coming for follow-up with some of the anticipated complications. So when I was operated for tetralogy of Fallot's, I was only 1. Now I am 30. What are my long-term complications? So a lot of it depends on the strategy, surgical strategy chosen. Transannular patch is typically associated with increased procedure burden later in life. Valve sparing initially is very good, but is associated with progressive obstruction in the long run. And RV2PA conduit, we are all aware, will eventually need replacement. So this is what happens in post-repair, post-tetralogy repair. If we are doing a TAP, there's chronic pulmonary valve regurgitation. In valve sparing, there is some residual RVOT obstruction, leads to remodeling and fibrosis, where the RV architecture changes from helical to oblique fibers, leading to RV dilatation and electromechanical dysynchrony, RV-LV interaction, which RV dilatation leads to LV compression, and finally arrhythmias. So what are the major complications? I've put reduced exercise capacity first because this is what they come to us with, thakavat. Next is pulmonary valve regurgitation, bronchial pulmonary artery, branch pulmonary artery stenosis, arrhythmias, and sudden cardiac death. RVOT dysfunction, resurgery or reintervention itself is a complication, left ventricular dysfunction and residuals, and aortic root dilatation. Let's get on with the topic. Reduced exercise capacity, which is reduced VO2s, this is how it is measured, is typically reduced in repaired TOF to almost 60% of appropriate for age and sex. This reduction is primarily due to pulmonary valve regurgitation, RV dysfunction, both systolic and diastolic, eventual ventricular-ventricular interaction leading to LV dysfunction, chronotropic incompetence, where the heart fails to increase the rate as per the requirement. Other problems being restrictive lung function, which is associated with cardiac surgery, and finally poor muscle strength in our patients of tetralogy of Fallot's. What are the influencing factors? Patients who are operated at later age, those with TAP, previous shunt surgeries, and most importantly, are associated with exercise intolerance. And lastly, not to forget, deconditioning from sedentary life due to overprotective parents and doctors. So low exercise capacity and poor response to heart rate are both associated with long-term poor outcome. It is seen that exercise training has been associated with good VO2s and decreases remodeling. Here is a photo of 2 Olympians. Mr. Sean, he is a snowboarder, he is post-operative TOF repair, whereas he's just post-operative bicuspid aortic valve repair, but they are participating. But let's not forget, they are 1 in thousands. Sudden cardiac death and arrhythmia are dreaded complications in post-repair tetralogy of Fallot's. VT being most common, fast monomorphic VTs are very common in these patients because the scars act like an anatomical isthmus. Atrial tachyarrhythmia with atrial flutter and fibrillation, again not uncommon, present you with heart failure and stroke. Bradyarrhythmia, high AV blocks are known to be associated with SCD. So it's critical to identify high-risk patients. In ECG, these patients will have prolonged URS complex, 180 milliseconds, and fragmented QRS, which is due to the scars or fibrosis in the RV. Ventricular dysfunction is an individual predictor of poor outcome. Symptomatic patients with NYHA class 2, 3, and documented NSVT, non-sustained VT, is an indicator for sudden cardiac death. Surgical factors like old age at repair is an indication, or requirement of palliative surgery is associated with SCD. Here are 2 images where they are showing fragmentation of QRS, and this is the one on the left side is an image showing NSVT run. How do we prevent it? Of course, by implantable cardioversion, by ablation for monomorphic VTs, by replacing pulmonary valve before irreversible damage to the RV is done, and of course medical therapy with beta blockers. Next, we're coming to pulmonary valve regurgitation, which can lead to right ventricular dysfunction, secondary tricuspid valve regurgitation, arrhythmias, exercise in decreased exercise capacity, and sudden cardiac death. These can be diagnosed or monitored in follow-up with echocardiography, most easily doable on follow-ups. Of course, even from second decade of life, we will be needing cardiac MRI to assess pulmonary valve regurgitation and RV volume. ECG is a good parameter to monitor RV dilatation. This is a guideline. If the patient is symptomatic, we consider pulmonary valve replacement. Then if it is asymptomatic, there is MRI guidelines of indexed RV volume more than 160 ml per meter square, or severe tricuspid valve regurgitation and atrial and presence of sustained arrhythmias are indication for pulmonary valve replacement in severe PR. Two approaches, surgical being gold standard, but in favorable anatomy, transcatheter pulmonary valve replacement can also be considered. Here's the flow chart telling the same thing. If the patient is symptomatic post or repair TOF with severe PR, pulmonary valve replacement is class 1 indication. If asymptomatic, and if any of the two following indications are present, which include RV dysfunction or LV dysfunction, MRI criteria, RVSP more than two-thirds of systemic pressure, or reduction in exercise capacity, is a indication for pulmonary valve replacement class 2A. If there is sustained arrhythmia, of course, that's an indication class 2B for pulmonary valve replacement. And lastly, if the patient will be reoperated for any other procedure, residual procedure, pulmonary valve replacement should be considered. RVOT obstruction is of course expected, especially in valve sparing. It could be residual or recurrent. Location can be subvalvar, valvar, supravalvar. Almost 37% of post-repair TOFs will present to us with some amount of RVOT obstruction, and 10 to 15% will also require a procedure. Mild RVOT obstruction is actually a paradox. About a gradient of 30 might be favorable for the RV, preventing RV dilatation and dysfunction. But of course, these patients are predisposed to progression of RVOT obstruction. So diagnosis again with the echo, CMRI being the gold standard. Presence of ejection systolic click, murmur can be an indication. Of course, repair will be surgical or balloon dilatation and stenting. RVOT dysfunction is a common problem that will eventually come due to chronic sustained PR and residual RV obstruction, surgical scars, which is now historic. Nobody opens up the RV, which causes dyskinesia, and conduit failure. Reintervention itself is a complication, and we would like to do it at the right time to give maximum benefit to the patient. Obviously, RV-LV interaction leads to LV dysfunction, so you would like to attend to the RV and the PR at an early stage before the LV is affected. And LV EF less than 55 is a poor prognostic sign. Our aortic root dilatation is associated with post-repair TOFs and individually associated. So what these guys really need is a core surveillance, a lifelong follow-up with a clinical history and examination. Echocardiography at our hand can keep us alert which patient should need intervention early. CMRI after second decade of life. ECG, a good indicator for SCD. And lastly, cardiopulmonary exercise stress test. This is a diagram just showing what can be done in echocardiography for RV function and CMR, a Holter monitoring for arrhythmias and VO2 measurements. So lastly, we have started a unit for pediatric cardiac surgery, but now we need to also train ourselves for adult congenital heart disease. That is the future. Thank you very much for this lovely morning.
Thank you very much, Dr. Sayukta, because panostatology So most of the time, the surgeon is perplexed. So we have to inform him every coexisting comorbidities because he needs to know each and everything. Then all these complications are partly preventable, particularly coronary artery anatomy as well, in addition to whatever we discussed right now. And well, monitoring is very, very important. And the problem comes particularly for RV failure when they get into PSPR.
Yes, sir.
These patients become difficult for any intervention also or any resurgery also. So that's the usual part. Most of other things you have highlighted very well. May I have comments from you?
I think just one mention. I had one patient, ma'am, just recently did pulmonary valve replacement. That patient, 21-year-old, 1 year severe RV dysfunction, lost to follow-up after surgery was done at 4 years, and then came into right ventricular failure. But still, I think intervention was done, and his 6 months follow-up is with me, and he's doing immensely good. So this patient, basically regularly if we follow, they don't end up with severe RV dysfunction, and we can long-term, and pulmonary valve replacement now I think is much less low risk as compared to, I think the surgeon will agree also, because redo in a talk, doing the pulmonary valve repair surgically, he will always prefer to refer this patient for a pulmonary
Catheter
valve
based,
replacement.
absolutely.
And they are doing really well.
Yes.
Pulmonary valve replacement.
All we need is a close surveillance. So before the RV starts failing, we do the needful. We put in a valve.
I have patients who have got pregnant post-op, PVR done, got pregnant, the babies are well, and she's still following her 42.
Yes.
And she's doing well.
I think a close monitoring,
So
a
positive
core
attitude
group.
towards, even if we see them late, lost to follow-up, and RVC looks quite bad, if arrhythmias are not there, complicating it, I think they do well.
Yeah.
Just wanted to make one comment about pulmonary valve replacement. It's something that we have to do practically in all tetralogies now. The important
Big
point is
burden.
we must not do it too early also. Because it is something that's going to last for 10, 12 years. As of now, whatever pulmonary valve we have is not going to last a lifetime. So we must choose the time very carefully. Of course, most of our patients are actually quite late because they don't come back. But I have also seen, now people are coming on follow-up and they've been advised to undergo pulmonary valve replacement earlier. So I think we have to be very careful both ways. We should not be doing it too early also, because anyway you have to do it again and again and again and again. Even if it is transcatheter, it's awfully expensive. It's about 15-20 lakhs for one pulmonary valve. Surgeons can do it for much less. So I think this is a dilemma that when to do. And now we have these nice guidelines which you showed, which are from ACHD guidelines of 2025, which are very nicely given us. And the important point is that even LV dysfunction is an indication.
Yes. Should never be missed. I think LV misses the focus in tetralogy of Fallots, but should not be missed. One eye on RV, the other eye on the LV. Okay, thank you so much.
Thank you.
Sometimes people come to you very late and they insist on surgery. The LV function is normal. I have a case with pulmonary atresia. He has MAPCAS. The MAPCAS is so big, it's causing pulmonary hypertension. So he was insisting on surgery, but no one was willing. The results are so bad. He's developed pulmonary hypertension. But actually, I put him on sildenafil. He's actually doing very well. He was coming. Pardon? He was having recurrent hemoptysis. But after sildenafil, his pulmonary pressures have not really reduced, but the hemoptysis has reduced.
Ma'am, it's practically impossible to do a unifocalization once the pulmonary hypertension has already been developed. If you do it early, you can prevent that.
He was 30 years when he came, but was really insisting.
Then the patient will not come off table.
That's what I do.
Okay, so with this, I would like to call upon the next speaker, Dr. Soumya Kasturi, on the Fontan paradox.
Good afternoon, everybody. Thank you, Vinkars, for giving me the opportunity to talk on this extremely vast topic. Every slide is a presentation in itself. Some slides will be redundant, some sentences will be said again and again and again. So I'm really sorry to this. It's a small presentation though. So I'm Dr. Saumya from Sri Padmavati Children's Heart Center, Tirupati. I'm talking on Fontan paradox. Why should we know about Fontan? We are all adult cardiologists. We don't need to know about Fontan. But unfortunately, the Fontans which we have done long ago, they are surviving very well. The survival now is more than 30 years in 87% of the Fontans. And there are 70,000 Fontan patients worldwide. Increasing adult Fontan population, which is almost like 55%. And as the age progresses, the Fontan starts to fail. What is the concept of Fontan? It started in 1971. It was designed for a single ventricle physiology. The systemic venous blood is connected to the pulmonary arteries by bypassing the right heart. So it's a circulation built without a pulmonary pump. These are the three types of Fontans. Initially, it used to be an intracardiac Fontan. Then they took a part of the atrium. This is the lateral tunnel Fontan. This is a complete extracardiac conduit, which is connected from the IVC to the PA. So it makes an extracardiac Fontan. This is what we are doing regularly now. Why does the pulmonary blood flow become passive? Because there is no right ventricle to pump the blood into the pulmonary artery. There is no pump to drive. And the flow depends only on the venous pressure gradient. You have an SVC and IVC which are connected to the pulmonary artery. So unless and until you have a pressure head between the SVC and the IVC, there is even a little gradient, the blood will not flow into the lungs. If the blood doesn't flow into the lungs, the blood doesn't come back, so you'll not have a cardiac output. So the entire Fontan depends upon the flow of blood from the venous structures to the pulmonary arteries without a ventricle pumping it. So what is the downfall of it? It is the elevated CVP, which is required to maintain the Fontan flow. So this is the Fontan paradox. In a normal heart, the pulmonary artery pressure is more than the central venous pressure, but in Fontan, the central venous pressure is higher than the pulmonary artery pressure because it needs to flow the blood. So it's a passive pulmonary circulation. And what is the end result of it? It is a low cardiac output with systemic venous congestion. So there are three physiological pillars for this Fontan. It is venous hypertension, elevated CVP, which is required to drive the pulmonary blood flow, pulmonary arterial hypotension. This is extremely essential, otherwise the blood doesn't come. The pulmonary circulation is like low pressure, it is non-pulsatile, and preload deprivation. Because the pulmonary arteries are stretched enough because of the passive circulation, during exercise or any times where extra cardiac output is needed, the preload is deprived, which limits the ventricular filling, causing low cardiac output. So how is the pulmonary flow maintained? It is central venous pressure minus the left atrial pressure divided by the pulmonary vascular resistance. So everything in this is important. The CVP needs to be high, LA pressure, in other words, the LV EDP needs to be low, which means your ventricle needs to have good diastolic function, even if it is a single ventricle, and the pulmonary vascular resistance has to be extremely low, otherwise the blood won't flow. So this is what we have achieved with the surgeries and everything. Why will it fail over time? It looks good, but why does it fail? It fails because it is a chronic venous hypertension. Because of this venous hypertension, there is lymphatic dysfunction and hepatic congestion. They will cause protein-losing enteropathy and plastic bronchitis, and there is progressive Fontan failure. So once we have done this Fontan circulation, you will have its effect on all the organ systems because the venous system is connected everywhere. You have Fontan-associated liver disease because there is hepatic congestion. You'll have fibrosis. It is associated with lymphatics like PLE and plastic bronchitis. There is reduced exercise capacity and renal dysfunction. So why are lymphatics connected to this? When you have an elevated central venous pressure, you have thoracic duct hypertension. I'll come to it in the next slide. So there are abnormal lymphatic channels and collaterals. There is lymph leakage into the organs causing plastic bronchitis and PLE. How come exercise physiology is deprived? We have a good heart, we have good lungs, the child does or the adult does not have any lung issue. But why do they have exercise intolerance? That is because it is again the same thing. The patient might have chronotropic insufficiency. The pulmonary capillaries are already dilated to the maximum. They cannot increase it more than what they need. So the end result of all this is reduced peak VO2, reduced VO2 max, and reduced FVC. what are the future solutions? Now we know that it is not going to be there, a very good pump in the long term. So what are we supposed to do? These are certain things which we can try to do, which is pulmonary vasodilators, which can be started even before, there is a study which is going on, like even before Fontan, immediately after the Glen also, even if the pulmonary artery pressures are normal, we are trying to give some sildenafil to see whether these children will have a better outcomes in Fontan. You can have, there are a variety of pulmonary vasodilators like ambrisentan, bosentan, anything can be added. And lymphatic interventions, that is because the thoracic duct is at hypertension. Mechanical cavopulmonary assist devices. This is an interesting thing which they said that because it is a passive flow, that is why it is failing. So let's put some pumps somewhere in the circuit so that it creates a pressure head which gives a pulsatile flow to the lungs so that the Fontan might not fail. And Fontan conversion surgery. Some of these children would have undergone a Fontan because the two ventricle repair would have been complex at that age, like 6 to 7 years. So with this 3D model, visual reconstruction, AI, everything, the surgeons might still try to convert it into a two ventricle, but it's a difficult thing, but yeah, they can still try to do it. And the last thing is heart transplant. When nothing happens, we have that. So there is energy loss in Fontan circulation. Why? As you can see, there is the SVC flow and the IVC flow, which is colliding at the pulmonary artery. There is loss of energy. You can see that the 350 is the red thing and 50 and 100 are the blue things. There is no red at all. There is nowhere red. The blood which is flowing is going at such low pace and low energy that there is so much loss in the entire Fontan circuit. This is the CFT model which has been studied. So they studied and said that even small pressure boosts, which give a 2 to 6 millimeters of difference between the CVP and the pulmonary artery, can help the Fontan flow better. These are all the subpulmonary pumps which have been studied over time, and they are trying. Most of them are in vitro models. They are studying to see whether the pulmonary blood flow can be improved with these pumps. Lymphatic interventions again, why do they have? Because the thoracic duct is engorged. The reason for it is usually lymph gets absorbed by the reverse Starling hypothesis. Here the CVP is higher, the thoracic duct is low. So the lymph gets filtered more. It doesn't know where to go because the thoracic duct is already dilated, the valves are already damaged, so it keeps leaking. If it leaks into the lungs, it causes plastic bronchitis. If it leaks into the gut, it causes protein-losing enteropathy. So how can we counteract it? You can do a selective lymphatic embolization to treat PLE, thoracic duct embolization, liver lymphatic embolization, lymphatic decompression procedures. All these are temporary. They will not stay long. Transplant in Fontan patients. Nowadays, we are getting referrals for a failing Fontan to do a transplant. Transplant in a normal, structurally normal heart or a DCM patient itself is a big deal in our setting. And Fontan, it's even more because these children would have a reduced pulmonary function testing. They would have already gotten sensitized with the blood transfusions prior. It will be a redo surgery. The PVR might not be as low as you would expect. The renal system, the liver and all would have been congested since a long time. They would have pulmonary AVMs and malnutrition. So transplant in Fontans is not an easy ball game. So the take-home messages are, Fontan circulation works without a subpulmonary ventricle. Pulmonary blood flow is passive and driven by systemic venous pressure. Venous hypertension is absolutely necessary to maintain flow. Chronic venous hypertension leads to multisystem complications like liver, lymphatics, and kidney. Future strategies focus on reducing resistance or adding energy to system to the pumps might help. So this is us, which we do day in and day out, balancing on that thin line. The heart which underwent a Fontan also does the same thing. It's not a cure for a single ventricle disease. It is just a delicate physiological balance and which we have to continue to optimize. This is us from Sri Padmavati Children's Heart Center from Tirupati. Thank you for giving us this opportunity.
Excellent presentation again. A very difficult topic indeed. Single ventricles, as we know, as of today also, we just explain the parents when they bring us the neonate or the infant that this will probably require a transplant in 25 to 30 years of age. But then I think one of the things which is very common nowadays in Fontan, because we are seeing patients who are 30 years follow-up and all, they do develop cirrhosis quite, the numbers are quite high. So even transplant probably is not an option for them. We'll have to just explain them that this is the kind of life they are going to have. And these are palliative surgeries, we all know that.
There are recent studies which have compared heart alone transplant and heart and liver in Fontaine together. The Western centers are doing it with heart and liver together. They say that the survival is better, but it's far for us.
It is not just fibrosis and all, there is hepatocellular carcinoma. That is the other problem, because I think at least one or two of my patients have gone on to develop HCC. So one has to be really very careful about that. And even transplant may not work if it is too late.
Yes, sir. They can cause Fontaine failure, sir. They are one of the reasons. Yes, sir. But the even, yeah.
There are patients who have a PVR of 2 or something. They're not normal, less than 1 like conventionally. Yeah, but all Fontaines over a period of time develop pulmonary artery hypertension. That produces further failure because the the CVP has to rise. So I think there are 2 big studies, one from New Zealand and another one I'm forgetting from there, which has shown that their survival, their symptomatic state of their CVP levels go down. So I think it works. With sildenafil only, not with ERAs.
There's an RCT which is ongoing, sir, from Chitra. So we are waiting to see the results.
So my request to the Cardiological Society of India, I know this is not Cardiological Society of India, but many of us are members, is to start something on the adult congenital heart, because this is a problem that we're going to it's going to really explode. I think in my practice, 80% of my patients are adults now. So this is what is happening, because the newborns are being taken care of. And now we are going to see, and as you said, all of them require, not just Fontaine, even a tetralogy requires a lifelong follow. So I think we need to, the CSI has to take some lead or, start these adult congenital heart disease training programs or.
So thank you very much. On behalf of the organizing committee and my co-chairperson, I thank all the speakers, panelists, and the message is very clear. Good surgical care, immediate care as far as possible, and good follow-up. That's what has been the highlight. So I think we are very well benefited. Once again, thank you everyone.
Thank you so much, our honorable speakers, our chairpersons, panelists, and moderator. I'd like to request you to please proceed for the felicitation at the presentation wall. And ladies and gentlemen, for the next session, we have our chairpersons, Dr. Asha Mahilraman ma'am, Dr. Priyank Jain, Dr. Chennaprada Sridevi ma'am, Dr. Martha Kaluzna, Dr. Ruchi Gupta ma'am. In expert panel, we have Dr. Priya Palimkar ma'am, Dr. Nogiku Nivamei, Dr. Varsha Kaul ma'am, Dr. Prachi Sharma ma'am. And as the moderator, we have Dr. Sujata ma'am. And ladies and gentlemen, as per the instructions from our organizing committee, I'd like to request you all to please concise your discussions after the talk. Officially, we have 8 to 9 minutes for the talk and 1 to 2 minutes for the question session. So I'd like to request our chairperson and moderator as well to please keep check on the timings of the talk as well as the discussion, as we are already running around 40 minutes late of the time. Ladies and gentlemen, please welcome our chairpersons, moderator, and our expert panel for the next segment of our sessions. That is by the title Win AP SIC Collaboration CAD in Women. And for the first talk of this segment, I'd like to invite our honorable speaker, Dr. Rini Pramesti, Madam, who will be talking about Menoka when MI isn't what it seems. Dr. Rini, ma'am.
I think I'm honored to do this session, which is a collaboration with APSIC. So we'll have the first talk.
This way. Good afternoon, everybody. It's honor for. Okay. Yeah. Okay.
I request everybody to be seated and listen to our Indonesian faculty who have come from so far.
Okay. Thank you very much. I'm very honored to be a part of the big meeting. Thank you for Dr. Sarita Rao and also all the organizing committee. And today I will talk about Menoka when MI isn't what it seems. I have no conflict of interest and nothing to declare. And the first is, what is Menoka? Menoka or myocardial infarction with non-obstructive coronary artery disease is referred to clinical manifestation. A patient present with the symptom of suggestive of acute coronary syndrome, and then elevation of cardiac troponin and also non-obstructive coronary artery at the time of coronary angiography. That means that there is coronary artery stenosis less than 50% in a major epicardial vessel. Actually, Menoka is much more working diagnosis rather than definite or final diagnosis. Menoka are more likely to be on a younger person, female, and less likely to be in a patient with the classic risk factors such as diabetes, hypertension, and dyslipidemia. I started the case report about 1 or 2 months ago. I have a patient, 25 years old woman, was referred to our hospital for primary PCI due to early onset STEMI with cardiogenic shock. At the time, the patient has just been more than 20 minutes with nausea, sweaty, and there is no history with hypertension, DM, or other cardiovascular risk factor. During the anamnesis, I got the information that the patient treated from GP 3 weeks before with measles, but the symptom is with fever and the rash like a bit red on the skin, and also the joint pain and also upper respiratory tract infection at that times. During the examination, ECG is evolution of MI with higher cardiac troponin, and during the coronary artery arteriography, we find there's no significant stenosis. I have a working diagnosis as Menoka. And at that time, I feel surprised because this patient is still young woman with no cardiac risk factor, but came with the cardiogenic shock. Can you see here? And his ECG is classical of anterior infarct with the life-ending high troponin, CRP, SR, ASTO, and also D-dimer. And I did the ANA profile. This is positive. This is the right coronary, normal. And then left coronary also normal, but we saw that a bit slow flow on the LED. And from the, maybe it's not clear, but I will explain later that there is a MRI for this patient. From echocardiography, we can show that the patient, okay, decreased LV function, the ejection fraction only 31.5, with the positive regional wall motion abnormality, with the chamber is still normal, and mild mitral regurgitation, TR on low probability of pulmonary hypertension. And we saw that from CAG, only non-significant stenosis with slow flow on LAD. From the MRI, we found that there is a positive regional wall motion abnormality related with LAD territory. And then we found that the patient have the subendocardial scarring and also transmural scarring, also in LAD territory. And we find that there is edema on the septal and the septal, yes, transmural, that's suggestive of myocarditis. And the first, we think that maybe the patients have MINOCA. At that time, I gave the diagnosis with STEMI. At the same time, because with the Jones criteria, patient can acute in rheumatic fever, and also the patient has systemic lupus erythematosus. We a bit talk about MINOCA. The prevalence is about 6 until 8%, with 1 year mortality 4 until 5%. There is not MINOCA is not final diagnosis, it's rather than working diagnosis, and we require to further evaluation. As we know that MINOCA, the etiology is coronary and non-coronary, and cardiac and with cardiac, with mechanism is spasm, SCAD, and then microvascular dysfunctions, and also myocarditis. How we do MINOCA explore, where we diagnosis stepwise, is the first we diagnosis with coronary angiography to confirm that there is no obstructive artery or vessel. And then, of course, we have to do the clinical review to rule out like the systemic disease like severe anemia or PA or something arrhythmia or sepsis or ATC. And then the most one of more important is intracoronary imaging. At the times, because the patient condition, we can undergo OCT. So we cannot get information from ACT, but we did the cardiac MRI, where this is very important, especially in the early days, because we have to difference between infarction, myocarditis, also the Takotsubo and other cardiomyopathy. And also, if we cannot get information for this, we need the functional provocative testing like to rule out vasospasm. As you know, at this patient, we find that it's defined STEMI, and also rheumatic fever, and then systemic lupus erythematosus, SLA. This is three entity is one difference between STEMI, rheumatic fever, and SLA, or both of them is one entity, one another is related. So we try to look for the patients as SLA. What is the related between SLA with myocardial infarction? As we know that SLA is high in the population with SLA is higher proportion of infarct myocard related with actually is coronary also atherosclerotic coronary more frequent, and also SLA have the pathway we thought with atherosclerotic pathway. At this time, I find that the patient with SLA has coronary microvascular dysfunctions, more than a half with the patient with SLA, and also patient with APS, they have different prothrombotic conditions, and also patient with SLE related with myocarditis, coronary vasospasms, mostly reflected by Raynaud phenomenon, and also chronic inflammation. And then another part is there is a relationship between rheumatic heart disease with Monica, and also that there is clue the coronary embolism, especially from micro perfusions. There is a related between the rheumatic arthritis with rheumatic heart disease with Monica. So the role of the patterns we need for myocardial infarction and myocarditis, we need to, and this patient related to the both of the myocardial infarction and myocarditis is related with SLA and rheumatoid heart disease. And the treatment, we have mechanism specific, so the patient still treatment with myocardial infarction, and also we treat with myocarditis as result of rheumatic heart disease, and also we treat with SLA. And outcome and prognosis for 5% years mortality. Mostly the patient with Monica, there is a lower than the classic MI during the prevention's adherence. And also from sweetheart registry, Monica patient has lower ongoing treatment use of aspirin, statin, or also is on IRB. So for the take-home message, menopause syndrome with many underlying mechanism. Angiogram is only early step. It should be pursued the mechanism. And cardiac imaging, cardiac MRI, increased diagnosis yield, and care therapy. Mechanism-specific treatment and close follow-up can improve the result and ensure appropriate secondary prevention. As SLA can worsen the rheumatic heart disease valvular pathology, and both rheumatic and SA independently and synergistically increase myocarditis, primarily through valvular embolism, microvascular dysfunction, antiphospholipid mediated thrombosis, and myocarditis. A patient with both rheumatic heart disease and SLA carry as compounded cardiac risk, and if the presence with ME, menopause should be actively considered in the workup, because the coronary artery may be appear unobstructed despite the ischemic injury. Thank you.
Thank you, Dr. Rini. We'll take the questions at the end of the session. Can you please join us on the panel? So we go on to the next talk for our spotlight lecture. We have Dr. Antonia Anna Lucchito, and she'll be talking on SCAD. Welcome. Can we have the slides on?
Yes. This one. Okay. Yeah. Good afternoon, everyone. Thank you for inviting me to this very amazing conference. My topic today is women are not a small men. Understanding coronary dissection in women, both SCAD or iatrogenic. Women are consistently has higher risk for procedure-related coronary dissection. Available PCI data suggest that women have a higher risk of procedure-related coronary dissection than men. With also not only PCI, but also balloon-based studies, and also the latest one is the CB study. All of them show that coronary dissection is higher in women than men. So I like to propose the conceptual framework about the SCAD across the female lifespan. SCAD is not a single disease, but a vascular vulnerability spectrum that evolve across the female lifespan. It is not come only one phase of our female life, but it continuously until the older age. So we all know that SCAD predominantly affecting younger women, and iatrogenic coronary dissection also observed in older women undergoing PCI may present different clinical manifestation of a shared pathophysiologically substrate character by coronary artery wall vulnerability. In SCAD, the underlying mechanism is typically related non-arteriosclerosis, arteriopathy such as FMD, or hormonally mediated alteration of the arterial media. In contrast, in older women, diffuse atherosclerotic and age-related media degeneration may compromise structural integrity of the coronary wall, predisposing the vessel to mechanical induced dissection during coronary implementation. Despite these differing triggers, both entities coverage on a similar final mechanism involving dissection or intramural hematome, suggesting that sex-specific vascular biology may play an important role in coronary wall susceptibility across different stages of life. So this is the pathomechanism that research indicate that the pathomechanism of women may be because of vessel fragility, hormonal influence, and anatomy and technique. Important to note that a study found that 4.7% of women with SCAD suffered an additional iatrogenic dissection during catheterization compared to 0% in control group. This is the case of coronary artery dissection in 68 years old female at proximal LAD, complicated by remote intramural hematoma at mid left main. The procedure started with fighting with the tortuous subclavian artery, and then we can see from the IFUS the diameter of the vessel is 3.25 or 3.5. So we put only 2.5 balloon pre-dilation. But what happened after, and also in very conservative pressure at 6 to 8 ATM. But what happened next, we can see there's dissection. So we plan to put a stand there to close the entry, and this is the result. So we can see no more dissection post-stand implantation. And we do the post-dilation with NC 3.25 at 6 to 8 ATM, again with very conservative pressure. So we may appreciate that this section at the proximal LAD was sealed. But we can see from the IFUS or from the angio that there is intramural hematome at mid left main, and it located remotely after the stenting. You can see. So we run another IFUS, and we may see that there's hematome there at the left main. So what we do, we just observe for several minutes, and we do the angio again, the IFUS. We may see that there is hematoma here. We can see the lumen is a little bit compressed by the hematome, and the RCA is dominant, non-dominant vessel. So this is the ECG before At the day after, we may see there is a mild alteration of STT changes, but after a week, she come back again and the ECG back to normal. And this case also complicated with the PAU, penetrating arteriosclerosis at the aortic. You may appreciate that from the CT, we may see the wall of the aorta is diffusely diseased. So aortic PAU is symbolize the systemic arterial fragility. PAU represent advanced atherosclerosis generalization of the aortic wall and is frequently associated with systemic vascular diseases including CAD. The presence of severe aortic wall pathology may indicate increased structural fragility of the proximal arterial tree. So is there any causal relation? We don't know yet because no study report that, but we may see that the coexistence of diffuse aortic ulcerative disease may represent a marker of generalized arterial vulnerability that could theoretically predispose to produce the complication. So this case raised the hypothesis that diffuse ulcerative aortic atherosclerosis may represent a systemic arterial fragility phenotype influencing the behavior of iatrogenic coronary dissection. So this is the summary. So we may hypothetically that say that sex-specific vascular biology may play an important role in coronary wall susceptibility across different stages of life. For younger women without any atherosclerosis, that is called as SCAD. And then middle age, we may see the mixed phenotype, SCAD risk, also complicated or combined with atherosclerosis. And the older women, we may see the clinical pattern is iatrogenic dissection. So we may call it as female coronary vulnerability spectrum. And this is me. We have to dive deeper because both the ocean and women's heart still hold many secrets. Thank you for
Thank you. Can you join us in the front, and we'll take questions at the end. Now we go to Dr. Meenakshi Kadiyala, and she an interesting title. She has angina, he has stent, understanding INOCA.
How do I do it?
Yeah.
Huh? I can just press here, huh? Okay. Good afternoon to the chairpersons and everybody. At the outset, let me thank the organizers for having given me an opportunity to talk. And I'll be talking on she has angina, he has a stent. And I mean, both have angina, but only he receives a stent. A decade ago, this could have been attributed to social reasons, ignorance, financial constraints, fear, and what is called as the Yentl syndrome. Yentl syndrome is, the name Yentl was based on a movie called Yentl, acted by Barbara Streisand, a 19th century actress who had to dress up like a male to go to school because because girls weren't allowed to go to school. And Bernardine Healy, doctor, in 1991 said that this is the username Yentl syndrome to describe that women were not receiving what the men were receiving as far as cardiac treatment was concerned. And 20 years later, Dr. Noel Barre Mers of the Cedars Sinai Heart Institute said that Yentl syndrome was still alive and kicking. This was based on 2 studies where women with ACS did not receive stents in spite of having obstructive CAD, and that resulted in a higher mortality and morbidity. And in January 31, 2016, the American Heart Association also put up a study which said that women tend to be undertreated compared to men. But I think Yentl syndrome is slowly disappearing, and if a woman doesn't receive a stent after she has angina, typical angina, we generally think of ANOCA, which is angina with non-obstructive coronary arteries. It has 40 to 50% of the elective CAGs for angina have no obstruction, and 20 to 30% of these have ANOCA. And of these, 50 to 70% are women. The recently seemingly increased incidence of ANOCA is probably because of better diagnostic techniques, better awareness, and also because of better risk factor control, where probably the pattern of atherosclerosis is changing with less obstruction, and also the rising prevalence of obesity and diabetes, which produce inflammation and coronary microvascular dysfunction. The risk factors of ANOCA is no different from that of obstructive CAD, and ANOCA is broadly classified into 4 categories. The coronary microvascular disease, where you have functional or structural alterations in the coronary microvasculature. You have vasospastic angina, which is in the epicardial vessels, and microvascular vasospastic angina, and the mixed diffuse disease, where you have a lot of disease, but which is not obstructive. And this is a picture which shows that you have the main, in microvascular disease, it's mainly the arterioles and the periarterioles, which are responsible for regulating the blood flow, whereas the epicardium is usually a conductance vessel. And anything in microvasculature would also produce ischemia in the absence of obstruction. Now, we all know the limitations of CAG. Angiography cannot detect vessels less than 200 microns, and angiography does not directly assess the vascular function, and 70% of the MIs are due to occlusion of a previously non-obstructed artery, and the number of segments involved rather than degree of obstruction is more important, and the diameter of the stenosis is compared to the diameter of the adjacent vessel, which is considered normal but need not be normal, and that there's a positive remodeling which can estimate the severity. And also, because of this, imaging is mandatory sometimes. See, most people who have chest pain go for angio, normal coronary angiogram, are considered not having CAD. So I think this should not be done until imaging has been done. Of course, it's expensive. Some people feel that instead of going through all the tests and the imaging, you just give them a therapeutic option, and if they are relieved, this is probably microvascular angina. And there are a whole lot of non-invasive tests, the PET, CMR, CCTA, and all that, which can, to a certain extent, delineate microvascular disease, but they are not accurate, and you have to go in for a invasive microvascular testing, and this is time-consuming, it's expensive, and everybody can't afford it. But anyway, you have a lot of indices. I can't go into details of all these indices because of lack of time. You have the FFR, the NHPR, the CFR, the IMR, HMR, and a whole lot of other Rs. And these will diagnose whether you have microvascular dysfunction. And of course, this vasospastic element can be diagnosed by provocative testing with acetylcholine or ergonovine. And when you give it and there is epicardial spasm of less than 90% associated with chest pain and ECG changes, then you think of microvascular spasm. But if there is a spasm of the epicardial vessel of more than 90%, then you think of epicardial spasm. Of course, you can't rule out associated microvascular spasm. So maybe if you do a repeat testing and it comes with lower doses, it comes with a shorter time, then you have to think of associated microvascular spasm too. And this is a picture which says my slides were not moving, so I didn't put any slides. But this is a provocative test where you see a spasm in the epicardial artery. And then there are a whole lot of flow charts and algorithms. I'm not going into the details, which says first you do angio. If angio is normal, you do imaging. If imaging is not done, you go in for a coronary vascular testing. The management of INOCA, evidence-based treatment is lacking in INOCA in view of the heterogeneous mechanisms and the paucity of well-designed clinical trials, and as a result of which all treatment for obstructive coronary artery disease have been tried with questionable or limited effects. You have the ACE inhibitors, beta blockers, statins, nicorandil, ranolazine, trimethazine, etc., nitrates, vesigot, ranolazine, trimethazine. I'll just go into this little new drugs, but still not really come into the, it's come to an extent, but still in the experiment.
Different names, right from broken heart syndrome to stress cardiomyopathy, apical ballooning syndrome, and now Takotsubo cardiomyopathy. The name is derived from, there is LV apical ballooning, which is seen, and it resembles a Japanese octopus trap. So who is affected? It is seen that it accounts for 2 to 3% patients of suspected ACS, and it is seen in 90% of post-menopausal women, and the mean age is around 67 to 70 years. So if we see there are various kind of stresses, some of them might even surprise you. The emotional triggers, it's more common in women, mainly grief, fear, anger, even a fight or even an argument with your partner. And in about 4% of patients, it is associated with a positive emotional stress, like a happy heart syndrome. And a physical trigger is more common in men, many associated with surgery, acute illness, or neurological events. As such, the proposed pathophysiology is that when there is emotional or physical stress, there is release of epinephrine, norepinephrine. And we see the apex of the heart, we have more common receptors which are more sensitive to epinephrine, which leads to more apical ballooning. And in the basal part, we have more of beta-1 receptors, which is more susceptible to the cholinergic receptors. And in the center, we have a transition zone for between the two. So it's a mixed combination of having microvascular dysfunction, multivessel spasm, inflammation, and even a nitrosative stress. So there are many of two types, the primary and the secondary one. And it is seen the one which we have a primary Takotsubo. These patients, they have moderate to severe LV systolic dysfunction. They have less LV complications, better recovery, a better prognosis, and less of reoccurrence as compared to secondary Takotsubo cardiomyopathy. And in 1/3 of the patients, there is no stressor. So if we need to differentiate between the two, it is seen there was a score which came up from the INTERTAG diagnostic score, which included parameters like female, emotional, physical triggers, absence of ST depression and QTC prolongation. And it was seen if the score is more than 50, it has a specificity of 95%, thus diagnosing Takotsubo cardiomyopathy. So there are various diagnostic criteria which have come over the years, and the most common ones are, which came from the Mayo Clinic in 2004, which was revised in 2008. Then it came from the ESC HFA task force and the INTERTAC registry. In all, it was seen there is a transient wall motion abnormalities in all of them. There was a stress was a trigger in all, but a neurological trigger was only described in the INTERTAC study. It is seen the coronaries are mainly clean, but in the INTERTAC registry, there was a coexistence of atherosclerosis. The cardiac biomarkers were mainly troponin in the Mayo Clinic. The rest two, they described the elevation of BNP and anti-pro-BNP. The ESC spoke about the recovery of LV functions after 3 to 6 months on imaging. And it is mostly the post-menopausal women are involved in the INTERTAC registry. So if we see the diagnostic workup, firstly the ECG, it is seen the patients may have ST elevation, ST depression, LBB, QT prolongation. If you see the differentiating factors, we see there is no ST elevation in the lead V1, and sometimes they have in the AVR lead, there is ST depression. So there could be an ST deviation in the stage 1 for first few hours, followed by T-wave inversion and QT prolongation. And the resolution of these features takes about months, almost 6 months. So as I said, there is cardiac troponin elevation, but slow as compared to that of MI. The BNP and anti-BroPNP are markedly increased. So if we see on the imaging, mainly the corneas are normal, but in 15% of cases, we can see a coronary artery disease. There is many apical ballooning. So the various variants which we have are the typical and the atypical ones. The ones which is typical is the classic, is the apical one, where there is the LV apical ballooning and basal hypercontractility in 70 to 80% of patients. In the basal one, which is a reverse Takotsubo, which has a nutmeg or artichoke appearance. The midventricular has ace of spade appearance, and the less common is the focal one. With the echocardiography, we can assess the regional wall motion abnormalities, any LVOT obstruction, any MR, LV thrombus. And in the CT MRI, we can see the presence of the myocardial edema that we spoke about, the differential receptor, that is the hinge point between the normal and the balloon segments. So when we need to manage these patients, first we need to do the risk stratification, and according to the Heart Failure Association, patients who are at higher risk are those who have aged more than 75 years, having systolic blood pressure less than 110, they have ejection fraction less than 35, they have MR, an apical thrombus, or a new VST. After stratifying, if the patient having a low risk and having ejection fraction of more than 45%, no treatment is needed. But if the ejection fraction is between 35 to 45%, we can consider a beta blocker or an ACE inhibitor. But if the patient is a higher risk, we have need of beta blockers, ACE inhibitors. If there is an apical thrombus, a need of anticoagulation for a period of 3 months, and the management of cardiogenic shock. As these patients have higher risk of reoccurrence, they need to be followed up, and these patients need to be at least on ACE or ARBs for at least period of 3 months till after they recover. So is this octopus in the jar really benign? No, it's not, because it is seen if we compare with ACEs, these patients have in hospital mortality of around 5%, and in the long term we see that the reoccurrence is around 10%. They have persistent LV dysfunction in 20% of patients. The MACE events go to as high as 9%, and all-cause death is seen in 5%. And overall, in the long-term mortality is almost equivalent to ACS patients. So there are various unanswered questions which remain in Takotsubo. Firstly, the pathophysiology. Mainly, the pathophysiology remains unknown. And why do some get it and others don't? Is there any role of genetics in it? These patients, despite having a very bad LV functions, their survival is very good. 90% of them recover. And the questions still remain unanswered, that why women are involved and what's exactly the mechanism of recovery. We need better tools for the diagnosis of Takotsubo and better treatment modalities. And new diagnostic strategies are needed to identify those who are at higher risk of reoccurrence. There is a lot of ongoing work in Takotsubo cardiomyopathy, that what is the role of estrogen, why we see it more in cancer patients. We need to identify the genes which are associated with it and which are predisposing. What are the chronic cardiovascular abnormalities in the survivors, which we can see through the CMR, any presence of fibrosis. And there are various new trials, RCTs coming forward, like the NACRAM and the Broken Sweetheart, which will give us more answers. So in the end, I would say 90% of them are women. Postmenopausal women accounts to 10% of patients. There is 5% in hospital mortality. 20% of them have persistent LV dysfunction. There is 10% chances of reoccurrence, and as such, there is no established treatment is proven till now. Thus, Takotsubo syndrome, it reminds us that heart does not have just pump blood, it also feels the stress. Thank you.
Thank you, Shivani. I think you spoke like a veteran. So really, congratulations, and we are pleased that the young Vinkars is going to carry the torch forward.
Thank you.
Sujata, can I ask a question? You have mentioned it's a stress cardiomyopathy, especially in women. How do you quantify stress in women? Whether 1 day stress, evening stress, morning stress, 3 month stress, 6 month stress, cumulative stress, morning, evening, nights. How do you measure?
So the stress has not been exactly delineated at what kind of stress it is. That's why
Can you measure stress in human being?
No, there can be, usually Takasubo follows a very extreme acute stress, but it can also occur if the patient has a chronic depression or a chronic stress.
My simple question, in human being, can you measure stress?
There are psychological parameters
No,
by
you
which
can
we
measure
do.
stress. Hair cortisol level.
Yes.
So next, Takasubo cardiomyopathy trial, which will be coming from Canada, they have included this patient 6 months, this hair cortisol level. It is a cumulative, maybe spikes also.
Okay.
So hair cortisol level should be included to really tell us that it is stress cardiomyopathy. If the cortisol level is normal, then maybe something else is operating.
But here they're not. But it's
You check the
also
Google,
been associated
you can
with the
get the
positive
answer.
emotion. Also.
Huh?
It's also been associated with the positive emotion as well, sir. It's not alone.
No.
We can
You
say
say stress. So how is stress? It may be one kind of stress for you, maybe another kind of stress. So can you quantify physiologically, scientifically? So hair cortisol level in last 1 month, 3 months, 6 months, 1 year can be measured.
Sure. Thank you for the input. We would like to ask you about Minoka. And I've had one patient with phospholipid antibody syndrome. After every pregnancy, she developed a complication. After the first pregnancy, a stroke. Then the second pregnancy, PLV branch thrombus. And then it turned out to be antiphospholipid antibody. Now she's on long-term acetylene. So also oral contraceptives in situ thrombosis can occur. So what is your other experiences with Minoka?
Yeah, actually, this is a special case because it's very young, but mostly the young persons, but not typically all these women. My patients I have experience about Minoka, most the young guys, and then have no risk factor. Then one the patients with SLA. And I have collaborations with doctor from hematology. They gave to prevent for the patients like the SLA to prevent, because not just Minoka, but also the thrombosis from the stroke, recurrent stroke, is related with the higher of microthrombosis. So syndrome is, our warfarin is good, but also that the patients not just, we give the anticoagulant, but also some the patients need give like immunosuppression, you know, like hydrochloroquine, and also the last is my Fortis, the drugs for immunosuppression for the patient with the donor syndrome, like the patient have renal transplants. That's also by my colleagues, she gave to the patients with antiphospholipid, because it is not just with Minoka, but also the patients with recurrent strokes are also higher in the patients with antiphospholipid syndrome.
Dr. Nivami, your inputs, anything on Inuka or Minoka, Takasubo, you can give your inputs as well.
About Takotsubo, do you think there are regional or ethnic differences in the its incidence or presentation?
I still wonder whether really the ANOCA exists in human being. If you put a word there, angina, with normal coronary arteries, you are doing not doing a justice to the typical angina Havard's definition. It has to be chest pain with normal coronary arteries. That's the best you can say. So chest pain with normal coronary arteries, chest pain with stent which was not needed previously, the best. Because the angina has a typical criteria, like getting exaggerated on exertion, getting relief with nitrates.
Definitely so.
But these are the people who has got normal coronary arteries.
Yes.
Never ever they will get
The question
typical
was on Takasubo, so let Shivani
Ask
answer
for
the
the
question.
agenda,
Yes, yes. Shivani, please answer the question.
As such, the ethnic difference, it was seen more in Caucasians population, it was seen, but in the Japanese, it was mentioned that as such, it is more common in men as compared to women, I guess.
Is that so?
Which I
Is
was
it,
reading, they have a more...
common in Japan and men?
Yeah, and it was more atypical presentation as compared to a typical presentation which we see, if I'm wrong.
In Japanese, そうですね、women、そうね、women is more,
Yeah, it is. Okay. Okay. And in Takasubo, even cardiogenic shock can occur. So in cardiogenic shock in Takasubo, you should not use too much of catecholamine stimulating drugs. That's very important. So you can, don't use dopamine, do not use much of norepinephrine. You can switch to vasopressin. You can also use levosimendan, which gives you better outcomes. So that is very important because catecholamine is at the root cause of it. That is...
I think we'll go on to the next session.
I just have one thing to say on Takasubo. The presenter said that the apical ballooning and the basal hyperkinesia was probably due to the difference in the concentration of the beta 1 and beta receptors. The beta 2 will allow more contraction, the beta 1 will allow more dilatation. Then how does reverse Takasubo occur? Where you have a basal dilatation and a apical. That is because what happened, these people are exposed to constant stress. So there is a reverse in the accumulation of the two receptors. That is the reason.
Thank you. I think we'll have a quick picture before we go on to the next session. I want to ask whether you all are doing testing.
Thank you so much, our honorable chairpersons, expert panel, moderator, and our speakers for the session for joining us. Ladies and gentlemen, without any ado, let's move on to our next session about Rhythm Masterclass. And to chair the session, I would like to invite Dr. Antonia Anna Lukita, Dr. P.K. Hazra, Dr. Sharda Sivram, Dr. Annapurna Kalia, Dr. Subhash Chandra, and in the expert panel, I'd like to invite Dr. Nikhila Pachani, Dr. Ritu Bhatia, Dr. Aishwarya Verma, Dr. Praveen Jaiswal, Dr. Shivani Rao. And to moderate the sessions, I'd like to invite Dr. Harshal Pamecha. Now please welcome our first speaker for this, the spotlight session of this session. SVT versus VT, the battle continues. Think fast and act right. Let's invite Dr. Aditya Kapoor, sir. Have a big round of applause, everyone, for our chairpersons, our panelists, our moderator, and our speaker.
I would like to invite Sir, Dr. Aditya Kapoor, sir. So after covering the session from congenital and CAD in women, will be covering the sessions which requires both the things, the rhythm master class. On to you, sir.
Thank you so much. It's an honor to be here. So I'll be speaking about SVT versus VT. So whenever there is a race of rhythms, and the narrow QRS versus the wide QRS, ECG becomes the referee. And we have all been flummoxed by ECG's rise from our MBBS, MD, and even our super specialization days. So I'll just keep it very simple. Most SVTs, can I have a bit of silence please over there? Thank you. So most SVTs will have a narrow QRS duration because they arise above the bundle of His. There are 3 exceptions. All of us should remember 3 exceptions when the SVT will have a wide QRS tachycardia. Only 3 exceptions. One, when there is a pre-existing bundle branch block. So you have to compare it with an ECG of a sinus rhythm. And if the For instance, this ECG shows a right bundle branch block. And if the ECG during tachycardia matches lead to lead with the pre-existing bundle branch block, it is obviously SVT with a pre-existing bundle branch block. That is one. SVT with aberrancy. So whenever you have SVT with aberrancy, of course the conduction is going down the left or the right bundle. So the ECG will look like a typical bundle branch block. So if it is looking like a typical RBBB, typical LBBB, it has to be SVT with aberrancy. If it is not looking like typical RBBB or LBBB, it's most likely to be a VT. And the third situation is when you have an antidromic tachycardia, that is you have an extra pathway. So it goes antegrade down the pathway and retrogradely down the node, you get a wide QRS tachycardia. So apart from this, all SVTs will have a narrow QRS, mostly regular. We will not discuss irregular narrow QRS tachys. So for regular narrow QRS tachycardias, remember you have three differentials, AV and RT, pathway or atrial tachycardia. So just by two maneuvers, you can understand what is the mechanism. One is analyze the RP interval and second is response to AV block. So I just not complicate it, keep it very simple. So when you analyze the RP interval, this is how you do it. You have the R and you have the P. So you see if it's a short RP tachycardia, most likely AV and RT or pathway. If it is a long RP tachycardia, that is the P wave is following outside the QRS, it is likely to be atrial or rarer forms of atypical AV and RT or pathways. So just show you some examples. So AV nodal reentry, pathway and atrial tachy. In AV nodal reentry, the P wave, the retrograde P wave falls right inside the QRS, bang on the QRS. So you can't see the P wave, it's like a P is buried inside the QRS, pseudo R or pseudo S pattern. In pathway, it falls in the ST segment and pulls down the ST segment, so there is a pseudo ST depression. And in atrial tachycardia, it is well outside the ST segment, so clearly long RP tachycardia. So here's a 40-year-old guy who had regular narrow QRS tachycardia. It's short RP. The P wave is not visible. It is following right inside the QRS, so you have a pseudo R, pseudo S pattern in inferior leads and V1. So this is AV and RT. Another patient, 50-year-old lady who had recurrent palpitations. Short RP, narrow QRS, P is falling in the ST segment, producing ST depression, remarkable ST depression. So this is not coronary artery disease. This is the pathway. And many patients undergo an angiogram, and the angiogram is of course normal. So this is how you distinguish AV and RT versus AV-RT. Another patient, this is a 16-year-old guy, recurrent tachycardias, P is falling outside the QRS. So this is clearly long RP, atrial tachycardia. So this is how you can distinguish. The second maneuver is response to AV block. So if the tachycardia terminates with an AV block, adenosine, carotid sinus massage, Valsalva, suddenly terminates, it means it's AV nodal dependent. So either AV and RT or pathway. This rules out an atrial tachycardia. So if it is terminating with a Valsalva, carotid massage, adenosine, by and large, it rules out an atrial tachycardia. Supposing you have a narrow QRS tachycardia, you give carotid sinus massage, adenosine, the tachycardia persists. There are more P waves than QRSs. This is diagnostic of an atrial tachycardia. This cannot happen with AV and RT or AV-RT. So these are the two things. You can differentiate AV and RT, pathway and atrial tachy. Coming quickly to wide QRS tachycardia. So remember, for wide QRS tachycardia, you can have an irregular wide QRS tachycardia. Three situations just like SVT with wide QRS. So I'll just show you some examples. If the tachycardia is wide, broad, irregular, fast, broad, irregular, this is pre-excited AFib. Never miss this ECG. It will not look like a typical bundle branch block, but it will be fast, broad, irregular, pre-excited AFib. If it is fast, broad and looking like a bundle branch block, that is likely to be AF with aberrancy. And the third example of a wide QRS which is irregular is polymorphic VT. So this, in a polymorphic VT, mostly in the setting of ischemic heart disease, the QRS varies in morphology from one morphology to another in the single lead. So this is how a polymorphic VT will look like. For regular wide QRS tachycardia, how do you differentiate from SVT versus VT? So 4 clues in my opinion. Capture beat, fusion beat and AV dissociation is the first clue. If you find them, it is VT. So you look for capture beats, fusion beats. If you're finding them, this is very, very diagnostic of VT. AV dissociation, how to look for that? Now P wave, remember, they are high polarization. They have a, the frequency is high as opposed to a T wave. So you look for changing STT pattern, humps and bumps on the ST segment, and look for the P waves in the inferior leads and V1. So I'll just show you this ECG. Wide QRS tachycardia looks like a right bundle type. I'll blow up the ECG. So if you see this humps and bumps on the ST segment, these are the P waves which are marching through the QRS, very, very subtle. So this is how you look for AV dissociation. If you find AV dissociation, capture beat, fusion beat, it's VT. The second clue is look for concordance. So positive concordance, that is V1 to V6 all positive, or V1 to V6 all negative, especially with the QS complex in V6. So this is very, very suggestive of a VT. Negative concordance is more specific than a positive concordance. The third clue is look for, again as I said, whether it's looking like a typical bundle branch block or not. If it is not looking like a typical bundle branch block, it has to be a VT. It cannot be SVT with aberrancy. So remember, for typical RBBB, V1 looks triphasic, V6 shows a dominant R wave. If it is not triphasic in V1, it's monophasic, and V6 shows a dominant S. This is atypical RBBB, most likely VT. For V1, V6 in LBBB, we know it's a sharp downstroke in V1 and a M-shaped complex in V6. This is how a SVT will look like. And in VT, it will be a slurred QRS in V1 and a QS complex in V6. So this will be a VT. So I'll just show you some examples. So this is a wide QRS right bundle type tachycardia. Now V1 is monophasic and V6 is looking like a QS pattern. So this is not a typical RBBB. This is most likely a VT. Another ECG, V1 looks like LBBB, but V6 shows you a QS complex, does not look like a typical LBBB. So this is again a VT. So it's pretty simple to diagnose if you understand the logic behind it. The last clue is axis shifts and some patterned ECGs. So if the axis shifts from sinus rhythm to at least extreme axis, if there is a more than 40-50 degree shift during the tachycardia, or a right bundle with left axis or the left bundle with right axis, that is discordant axis, then it has to be a VT. Two patterned ECGs, remember, fascicular VT and RVOT VT, usually in the setting of a normal heart. So idiopathic LVVT comes from the inferior part of the septum. So you'll get a right bundle branch block with a superior axis with a narrowish QRS, normal, structurally normal heart, because this is coming from the fascicle. So right bundle, superior axis, normal heart, and a narrowish wide QRS. RVOT-VT again coming from the RV outflow tract, so it will look like an LBBB with an inferior axis. So remember these two patterned pathognomonic ECGs. So I'll close here. Remember these two algorithms also, the Brugada algorithm and the Verikes algorithm. The Brugada taught us what we have been discussing. So monophasic or a concordance, that is absence of an RS complex, slurred QRS, AV dissociation, or a atypical bundle branch block pattern. And this is the Verikes criteria. He says that look at lead AVR. If AVR shows you a dominant R, it is likely to be a VT. If AVR shows you a QR, likely to be a VT. If AVR shows you slurring, likely to be a VT. So I'll close here. The tachycardias are an important diagnostic challenge. AVNRT, AVRT, AT, you can diagnose by the RP interval. And if you remember, capture, fusion beat, AV dissociation, concordance, typical or atypical bundle branch block, axis shifts, patterned ECGs, you will be able to make the diagnosis nearly 90% of the times. Thank you for your attention.
With a patient with acute chest pain, again P is inverted in lead 1, QRS is negative, but this is not limb lead reversal. You can see non-progression of R waves in the precordial leads, and ST elevation in V1 more than V2. This patient had situs inversus with dextrocardia with antral MI. Dextrocardia per se will not cause P inversion in lead 1. This is a situs inversus because the atrial situs goes with the abdominal situs. This is another ECG with P inversion. I am trying to highlight the causes of P inversion in lead 1. Here there is QRS and T are upright. You can also see P inversion in lead 2, V4 to V6. And this is a left atrial rhythm. Mirowski's criteria. Mirowski is the inventor of ICD. P inversion in lead 1, doom and dart appearance in V1, and P inversion in V6, what he said is essential and the most specific sign to differentiate from nodal rhythms. This left atrial rhythm is known for left atrial fibrillation and other arrhythmias. So this is the article by Mirowski, and this is the typical ECG he described with 3 criteria for left atrial rhythm. This ECG shows a prominent P waves, tall peaked P waves in inferior leads and most of the precordial leads. And you can also see prolonged QT. So tall peaked P waves is suggestive of right atrial enlargement, popularly known as P pulmonale. So this patient had severe hypokalemia, potassium level of 2.2 milliequivalents or less. With the correction of serum potassium, the P wave amplitude gradually decreased to normal. So this is called a pseudo P pulmonale pattern associated with severe hypokalemia, which is transient and is corrected by correction of hypokalemia. There are a few case reports. The usual ECG changes in hypokalemia are ST segment depression, T wave inversion, and prominent V waves. There are less report on morphology of the P waves. Why there is prominent P waves in severe hypokalemia? The exact mechanism is unclear, but it may be because of hypokalemia, sodium ion can easily enter the cell and the action potential can easily rise up. Another postulation is overlap of P wave and the U wave. Next ECG is a 30-year-old male asymptomatic. You can see J point elevation, ST elevation with concavity upwards, and the prominent T waves, called as early repolarization pattern. We used to call it as early repolarization syndrome earlier days, but now we call it as pattern. J point elevation of 1 millimeter or more in 2 or more contiguous leads with ST elevation, concavity upwards, and prominent T waves, seen classically in lateral leads and sometimes in inferior leads also. So this is seen in nearly 1 to 13% of the population, most often in young males. This was considered as benign, but recent studies have shown that it's a potential risk factor for sudden cardiac death due to polymorphic VT or ventricular fibrillation, so-called early repolarization syndrome described by Haisegure in 2008. They tried to identify some high-risk features like horizontal or descending ST segment has a higher risk of VF. And if this is seen in inferior leads or infralateral leads, and if it is global, there is higher chance of malignant arrhythmias. Next ECG is a short QT where there is hardly any ST segment and tall T waves. The QT is corrected QT is less than 330 milliseconds, and this is a rare familial form of channelopathy described by Gusek in 2000, and hardly less than 300 patients are reported worldwide. Maybe it is underreported. These patients can have paroxysmal atrial fibrillation in 1/3, and the first manifestation can be a syncope or sudden cardiac arrest due to ventricular arrhythmias, malignant ventricular arrhythmias, and there is family history of sudden cardiac death in 1/3 of the patients. Like in long QT, there are criteria, diagnostic criteria, Golub score, short QT syndrome, depending on the QTC, clinical findings, family history, and genotyping. We have a patient with 74-year-old, this I got from our electrophysiologist, Dr. Bharat Raj. This patient was diagnosed with seizure disorder at the age of 41 years on multiple anti-epileptic drugs. In spite of multiple anti-epileptic drugs, he was getting multiple episodes of loss of consciousness and even a resuscitated sudden cardiac arrest due to VF. ECG showed a short QT with QT 323 milliseconds and multiple ectopics. 24-hour Holter showed multiform VPCs, short runs of atrial fibrillation and NSVT. Patient was put on ICD and quinidine. Last 1 year, he did not have any shocks. This is a narrow QRS tachycardia, which is irregular. You can see different morphologies of P waves, more than 3 different morphologies of P waves, simple ECG, suggestive of multifocal atrial tachycardia. We see less often because it is more often seen in patients with exacerbation of COPD, which predicts poor prognosis. This is a malignant arrhythmia. This was one of our male patient, young male patient, presented with recurrent palpitation syncope. Regular, fast, sir showed irregular, fast, wide QRS tachycardia. Here it is regular, fast, wide QRS tachycardia. After cardioversion, there was anomalous pathway, pre-excitation. This was a pre-excited atrial flutter with 1:1 conduction, which may be seen in up to 70% of WPW. Because accessory pathways can conduct rapidly, 1:1 conduction is possible. On AV node, it is not possible. This may be mistaken for VT, or it may degenerate into VT and VF. This ECG shows a long QT with T inversion, and you can notice there is alteration in the T wave morphology suggestive of repolarization heterogeneity causing T wave alternance. This is a predictor of malignant ventricular arrhythmias in patients with long QT. Last ECG is a 25-year-old female with a systolic murmur. You can see rightward axis, RSR pattern in V1, and you can see notching of QRS in 2,3 AVF, suggestive of croquetage sign, which is highly specific for ostium secundum AST, especially when there is large left-right shunts. This was described by Heller in 1996. Thank you.
Thank you, ma'am, for the session. We'll take the discussion again in the end. Next, I would like to invite Dr. Abhishek Rathod to speak on conduction system pacing when pacing is left to right. On to you.
Thank you, Dr. Ishal. Thank you, WINCARS and WCC for giving me the opportunity. So today I am going to discuss about the conduction system pacing. It is a lot of controversies till now. People thought that the RV apical pacing is better. Means these patients do well in the future. Even some say that septal pacing is better than the apical pacing. But the current guidelines, the current data made it very clear that CSP plays a very important role and it prevents pacing-induced cardiomyopathy. So in 1925, Wiggers first highlighted the detrimental effects of RV pacing, which occur due to asynchronous activation of the ventricles. Pacing at any myocardial site, whether it is RV apex, RV mid-septal or high septal, it leads to the detrimental hemodynamic effects in the form of development of heart failure, LV dysfunction, symptoms, atrial fibrillation, and heart failure hospitalization. Initially, actually, there was a lot of small studies which there was very mixed results. Some studies told that RV apical pacing is better. Some studies told that RV septal pacing is better. But recently, new data has come in which more bigger randomized trials were done. And they clearly mentioned that RV septal pacing doesn't help. So this study was published in Europace. It was a randomized trial in which 100 patients were enrolled. And they clearly mentioned that septal pacing is inferior than, septal pacing is not better than the apical pacing. This was the biggest study so far. It was a PROTECT PACE study in which 240 patients were enrolled. And they also clearly mentioned that even RV higher septal pacing it doesn't provide any protective effect as compared to the RV apical pacing. So both the apical pacing as well as septal pacing, it leads to pacing-induced cardiomyopathy. The incidence is big. It is 10 to 20% over a period of 3 to 4 years. The pacing-induced cardiomyopathy is not only development of LV dysfunction, but even if the patient develops heart failure symptoms, they develop atrial fibrillation, they develop increase in the level of natriuretic peptide, that is also labeled as a pacing-induced cardiomyopathy. This is a mechanism of pacing-induced cardiomyopathy. The RV pacing, it leads to the dysynchrony, both intraventricular as well as interventricular. It leads to the myocardial fibrosis, altered hemodynamic changes, altered cardiac metabolisms, which leads to LV dilatation, LV dysfunction, or development of MR, which can be reversed with either BIV pacing in the form of CRT or conduction system pacing if do early. So conduction system pacing is further divided into two parts. One is His bundle pacing and one is left bundle pacing. In the initial days, His bundle pacing was more preferred, but it was found that there were a lot of problems with the His bundle pacing because the His bundle, it's more of an insulated structure and it's a very narrow structure. So lead dislodgements were more, the threshold issues were more, and the P wave oversensing was there because His bundle is more of an atrial structure. So P wave oversensing was there, and the R wave undersensing was there. So there were a lot of issues with the His bundle pacing. So later on the concept of left bundle pacing has come. The left bundle is further divided into anterior fascicle, septal fascicle, and posterior fascicle. So we got a very wide area for conduction system pacing. So these are the various entities in which LV septal pacing is not considered as a conduction system pacing, but it is considered as a left bundle branch area pacing. While deep septal pacing, it is also not considered even under the left bundle branch pacing. So it is not a conduction system pacing. It should not be preferred. So the problems with the his bundle pacing we have already discussed. Now recently one more concept has come for the hot CRT or lot CRT, which is nothing but just combining CRT with the conduction system pacing. This was a very big study done by Zabriskie et al. What they found that the mean QRS duration in the patients at the baseline was 182 milliseconds. When CRT was done in those patients, the QRS duration reduced to 170 milliseconds. Or when left bundle pacing was done, the QRS duration reduced to 162. But when they combined both left bundle pacing as well as CRT, the QRS duration reduced to 144 milliseconds, which was a very significant number. Even if we talk about the ejection fraction, the improvement in ejection fraction was much more with the lot CRT as compared to the bi-V pacing or left bundle pacing. This you can see the ECGs. This is the baseline ECG showing the left bundle branch block. After doing CRT, you can still see some notch. You can see here in lead 1, there's a notch. And the QRS is narrow, but not much. Then this is the ECG with the left bundle pacing. Again, the QRS is very good. Even the notch is not there. But if you can see here in this V2 and V3, the notches are there. And in the lot CRT, you can see a very beautiful result, very narrow QRS, no any notches are there, and the outcomes were better. So the lot CRT, it provides superior resynchronization as compared to the CRT and left bundle pacing, but the only problem with the lot CRT is that it is technically more demanding. You have to do two big procedures. You have to do left bundle pacing as well as CRT. So when to do CRT? If there is an indication for CRT, when to do conduction system pacing? So in the patients in which there is an indication for CRT, we can do CSP in those patients. The patients who require ventricular pacing more than 20% or post-AV node ablation in patient with atrial fibrillation. So these are the various tools which most of us are familiar. This is a Medtronic 3830 lead. It is active fixation lead in which the screw is already out. This is the CE315 HIS. It is a three-dimensional sheath which is used to screw this lead. These are the sheaths from the various manufacturers in various shapes. This is a large curve sheath, small curve sheath. Large curve is used for the dilated hearts. Small curve sheath are used for the smaller hearts. And this is the Agilis Pro sheath, which is a deflectable sheath. So these through these sheaths, we can use our routine pacemaker leads also, which is also called as stylet-driven leads. So how to do conduction system pacing? First of all, before doing conduction system pacing, just evaluate the septum. Just rule out if there is any septal scar or not. Measure the septal thickness. Then mark the HIS. Put a HIS bundle catheter. Put a RV apex catheter. Then our area of interest will be just 1.5 to 2 centimeter below this HIS region. This is our area of interest. So take the sheath inside the right ventricle, abut with the septum, and then starts and take your lead and just touch it at the interventricular septum and start pacing in the unipolar mode. This is the unipolar mode in which the black port should be attached to the tip of the lead, and the second red port, it should be attached to the pocket, and start doing unipolar pacing. You can see, once you pace in unipolar mode without screwing in the lead, you will get a W pattern in the lead V1. And once you screw the lead inside, this W pattern will goes up and slowly you will get a R wave. You can see in the last figure, you can see a R dash pattern, which suggests that you are capturing the left side of the septum. So this is the evolution of QRS complexes while doing pacing. You can see here in the first, the RV septal pacing. Once the lead goes in further, the R dashes appear, QRS has become narrowed, and when the lead goes further in, that is in the LV septum, the R dash becomes more prominent, QRS further reduced, and when you capture the left bundle, QRS duration, this is not a QRS duration, it is a R wave peak time, it further reduced to 68 milliseconds. So here comes the role of LVAT, that is LV activation time, which is a very important electrophysiological parameter which we can measure by using EP system mainly. So this LVAT is the interval from the pacing stimulus to the peak of the R wave. So by measuring this LVAT, we can get to know that whether we are capturing the left bundle branch area or not. So if there is, So if the duration of this LVAT, it shortens abruptly at different output, it suggests that you have captured the left bundle. Or if both at the high output or low output, your LVAT is small, it's less, then it suggests you have captured the conduction system. So this is a one more new approach nowadays. When we screw the lead in, you may get a lot of PVCs also. So with that PVCs also, you can monitor that how much depth we have to insert the lead. You can see here the QRSs are wide, and once we are screwing the lead inside, there are a lot of PVCs, but these PVCs are gradually getting narrowed, and you can see one R dash in the lead V1. This is nothing but a template bead. This is the QRS which we want. So it is called as template bead. So PVC guided screwing can be done. So now how to know whether the pacing is selective or non-selective? We have to pace at a different output. We have to pace at the different output. If here you can see at the 4 voltage the LVAT is 90, and once we reduce the output, the LVAT remains constant, that is 74 milliseconds. So it suggests that capture is selective. And if the QRS is wide, LVAT is more, even at the high or low output, it suggests that this is a non-selective pacing. These are the various ECGs. We are not going into detail. When you capture anterior fascicle, ECG is different. When you capture septal fascicle and posterior fascicle, ECGs are different. So when to stop screwing the lead, just measure the impedance. If your impedance falls more than 200 ohms from the baseline, you stop screwing. Or if the impedance of the lead is less than 450 ohms, in that case you have to stop. So the complications, you may get septal perforation, you may develop complete heart block in the patient who has left bundle branch block. You can have you can injure the septal artery, which is remains inside the septum. So if we talk about the guidelines, in guidelines also it is clearly mentioned that there is a role of conduction system pacing. Now very common question asked by some people that whether it can replace CRT or not. So it is very clearly mentioned in the guidelines that if the patient is having left bundle branch block, ejection fraction less than 35%, with QRS duration of more than 150 milliseconds, CRT will remain the first line indication. CSP cannot replace CRT. We should do CRT first. Suppose if you are not getting good veins, you are not getting good parameters, in that case, we can use conduction system pacing. And sorry, because of lack of time, it's very difficult. Okay, I will present this last case. She was a 62-year-old female, ejection fraction 25%. She came with recurrent heart failure. CRT was tried earlier in a different hospital where the vein was not suitable. So we did conduction system pacing in this case, and you can see the very good QRSS complex are there. And when she came to follow up, right now her ejection fraction is 45%, and she is doing well. So my take-home message from this talk is that pacing at any myocardial site, whether apex or mid-septal or high-septal, it is always detrimental. Lot CRT may be considered in those cases where bi-V pacing or CSPs it is suboptimal. Full effort should be made for selective conduction system pacing for better outcomes. Deep septal pacing is not recommended, and it is not considered as conduction system pacing. RV pacing is contraindicated if the pacing requirement is more than 20% or ejection fraction is less than 40%. If CRT fails in pacing-induced cardiomyopathy, conduction system pacing is a treatment of choice. And the patients undergoing pacemaker implant who are expected to require pacing percentage of more than 20%, in that case, CRT can be considered. Thank you. Sorry, CSP can be considered.
Aditya has left, Dr. Kapoor? Is he there? No? So that's the problem.
Take question answers just after the talk. May I ask one question, sir?
Yeah, definitely.
See, the thing is, when we are doing left bundle pacing, do you do echo and measure the thickness of the septum? That's number one.
Yeah.
Just to not to perforate, that's number one. And secondly, second question is, what do you do when you have a septal scar? Because the scar will, the thickness will be really minuscule, and that may not help you in, left bundle pacing in these situations. So do you routinely do, and what is the optimum thickness of the IVS you need for left bundle pacing?
So definitely, ma'am, before doing such cases, we need to see the septum, because if there is a fibrosis, there is a scar, it is very difficult to penetrate this lead, especially lumenless lead. But suppose if you get a lot of scar, a lot of fibrosis, in that case, that stylet-driven lead we can use. So, so we should see septum. Some people do cardiac MRI also, but most of the patients, when they come for the complete heart block, we have to put temporary pacemaker in those cases. So we cannot do cardiac MRI. But for those patients who come for the CRT indication, LV dysfunction, left bundle branch block, in that case, I think we should do cardiac MRI also to rule out scar, to know the fibrosis.
What is the thickness, optimum thickness you need at least?
There is no such criteria for the thickness actually, because suppose if the septal thickness is around 7 to 8 mm only, in that it is not necessary that we should put both the cathode as well as anode inside the septum. Even if the anode is hanging outside, it is okay. We can do unipolar pacing in those cases.
Fine.
So septal thickness is not a criteria.
Yes, and bundle branch block, bundle branch pacing is really come up very well, because it's like poor man's CRT.
Yeah.
Because people who cannot afford CRTD, definitely CRT, then those patients we can always offer them left bundle pacing. That is definitely better than just RV pacing.
Yes.
I mean, that's also a new thing.
Yes, ma'am.
Just please.
We are talking about the scar. Scar is makes the septum 5 to 6 mm, and it's very thick to go in. And in elderly patients, even if you sometimes find the septum is about 10 millimeters, you still may not be able to penetrate because of those fibrotic scars. Then ideal area, another area where you can go in is the posterior fascicle. You bring down and go into the posterior area. Sometimes if you catch the fascicle, you'll get a narrow QRS.
Definitely.
He has shown the image.
Yes.
So how do you get to know that you are hitting the fibrotic band? So suppose you are using Medtronic, Biotronic, so two different mechanisms, stylet best and non-stylet best. If you are using Medtronic one and giving this clockwise torque, if there is a fibrosis in front of the lead, it gives back. It turns back. Like it will not move forward. Now, if you have a sweet meat, a very nice muscle, give 5 turns, 6 turns with Biotronic St. Jude, it will enter. So then you change your side. You come out, anti-clockwise you come out, and you should, as he is mentioning, not the anodal capture. It has to be unipolar.
Unipolar pacing.
Yeah. We do not do any, I have done more than 500 CSP. I've never done any pre-op echo. So EP specialists, they do differently. So in 500 cases, initially used to take 1 hour, 2 hours. Now I can do CSP 10 minutes, 15 minutes, much faster. So what I do the RV angiogram. Because if you have pacemaker lead in place, post-bypass patient, the ventricle, the structure of ventricle completely changes. The septum, you have to look in the septum just like 11 o'clock, 5 o'clock, and go at 1 o'clock, 2 o'clock, 10 minutes down. But if you have a pacing lead, ICD lead, CRT lead already there, it's very difficult to judge where the septum is. Septum sometimes it is saucer-sepate. If a saucer-sepate septum on an angio, it will be very difficult. If you see a straight line on angiogram, then it's very easy, as he was showing one case there. So my question to you, how do you do the leadless conduction system pacing?
Leadless on?
Leadless conduction system pacing.
Leadless conduction system pacing.
Yeah. As second is there any difference going, when you're not getting, as ma'am was asking, the fibrotic band on the upper third, typical position, you try the middle third, fibrosis again, nothing is penetrating. Do you go lower and lower
to change the positions.
Is there any way to go, how much lower you can go?
Even we have
From
got
ideal position to non-ideal position.
Yes, sir. first definitely we should try the basal septum first, basal anterior septum, which is the most preferred area. If we are having difficulty in screwing the lead, then we can go in the lower septum, if basal lower septum. Even if there is a fibrosis, we are not able to penetrate, just go to the mid, then mid upper, mid lower, then apical lower, apical. We have to go like that, sir. Leadless, right now there is no any choice, but the company people are saying that they are working on that. They are making some leadless devices which can go inside the conduction system also. So we are also waiting for that, sir, because this is a problem with the leadless pacemaker, because we cannot do conduction system pacing with that.
So
Yeah.
Can I extend it?
Yes, please.
So when you're doing this conduction system pacing, the most important aspect of it is that you're catching one fascicle of conduction system. That means your left ventricular activation time has to be short, your QRS has to become narrow, and when you look at the 12-lead ECG, you need a transition, because if you are on the septal pacing if you are doing, that means from your V1 to V6, everything will be negative. Transition should occur, LVAD should be there, QRS should become narrow. These are the three most important criteria.
Yes, definitely.
So if I
And
give
one
one
more-
example, you in V1, you are looking at narrow QRS LVV line. In V1, you are saying RBB pattern. Which one is better?
We should not look only the V1, because in V1
I
RS...
told you only
QR,
V1.
V1 QR pattern.
QS
You
pattern.
need QR pattern.
QR
R,
pattern.
at the
Typic-
terminal R should come.
Yeah.
That means you have captured the conduction
Left
system.
So if you're actually hitting the left bundle, pacing it, it will look like RBB.
Yes. That's
So if it
why
looks like
R.
RBB, you are sure you are hitting
That's
the
why
left bundle.
terminal R.
No, what I'm saying in V1, suppose you have full-fledged RBB, RS, and a QS. Which one is better?
QS is not
Ideally,
better.
you're
QS
right.
narrow QRS with a notch in the upstroke of the S
You
wave.
need to go more in.
Or in.
Yeah,
But-
you should give one or two screws
But
more.
we should see V5 and V6 also. That is very important,
Yes,
actually.
V5,
We should not
V6
consider
also
V1
should be
only.
seen.
One question can I ask, ma'am? Regarding, basically we get a lot of young patients with manifest WPW on ECGs. They may come for fitness or, just for job fitness or something. So how do we risk stratify these? Or do we send them for EP study? Because, they have really gross delta waves and ECG looks gross. So many a times they are worried what is their future? Will they develop any kind of arrhythmias in future? Because in one of the ECGs you showed that, these patients can have, if they develop atrial flutter fibrillation and then they can have, it can degenerate into VT and then these patients can have sudden cardiac death, especially AVRTs. So how do we risk stratify them? Do we do treadmill tests to see antegrade, AV conduction, or you send them for provocation, or we send them for EP? How do we do?
usually send to our EP colleagues.
EP colleagues.
Yes.
Okay, and maybe EP colleague would answer that question. So what do you do? Because it's very commonly seen. And so do you send them for EP, or you do treadmill and see AV conduction, antegrade, and if you are good AV conduction at 180 also, the QRS narrows, then just leave them for, observation, or what do you do?
Actually, in our initial days, it was told that we should do TMT. Let's see how much the AV node, how much the pathway is
Yes.
conducting. But right now, in the current guideline, they have clearly mentioned that once you diagnose a WPW pattern in your ECG, these patients should be subjected for EP. Because what happens the day on which you are sending to EP, sending for treadmill tests, on that day, what is the patient's sympathetic drive status? Drive? We don't know. That sympathetic drive, parasympathetic drive, it changes actually. So doing TMT in WPW ECG pattern is fading away right now, and these patients should be subjected for EP study only.
Only one point I'll add to this is, if we are getting an intermittent pre-excitation on TMT or on EP study, if we are getting the good AV nodal conduction, or the shortest pre-excited RR interval is less than 250, then we should definitely ablate. If the AV nodal conduction is good, then we can just leave it. Or if there is an intermittent pre-excitation, we should leave it.
You get actually that manifest WPW becomes narrow QRS, absolutely at 180, 160, 170. Then I think, I mean, that's what clinical practice we have been doing, just send them for, more practical approach. But if these are the new guidelines, and I think we need to change our strategies.
But that's, this is I'm saying, ma'am, means day to day it can change. On one day at 180 rate, maybe pathway is not conducting. On another day, maybe it is conducting. It changes with the sympathetic drive. So,
Antonia ma'am has. I'm sorry. Which one, according to you, the impact on the long-term heart function, the lead that induce TR, or the position of the lead in the apical?
means you want to ask whether CRT is better or CSP is better?
Lead. I mean the lead. Yeah, one leadless and with lead. With lead, you can induce the TR, right? Lead at RV. Yeah. And then the lead position at the apical also has worse prognosis.
Yes, ma'am. There's no doubt about it that RV apical pacing and even the septal pacing, they are associated with the worse outcomes. It is very clear in the guidelines. Last year, in 2025, there was a big conference in Vienna, and they have written a consensus statement. In that also, they have very clearly mentioned that RV apical pacing and septal pacing should be discouraged, especially if the patient pacing requirement is more than 20%.
Well, thank you, Dr. Abhishek, and it was an excellent session. We'll close the session and carry on with the next. We'll take for the.
Thank you so much, sir.
Dr. Abhishek.
I'd like to request all the speakers to please join us on the dais for a group photograph.